And good morning, everyone. Happy Saturday to everyone, and welcome to PerfWeb 81, day number 3. And we want to thank everyone for being here with us this morning. We're going to have an interesting program. We're going to be displaying, you can bring it, but thank you. We're going to be displaying SimMan today, doing some really cool simulations. Thank you so much. And we've got a great faculty today, as you can imagine, right next to me, Kimberly Spurlin. But before I do your introduction, I'm just going to go through real quick. If you want to reach out to us for whatever reason, just contact us at contact@perfusioneducation.com. There you see it down at the bottom of the screen. Our call-in number, it'll be on all the time. You're welcome to call in whenever it's convenient. If you'd like to be live on the air, make a comment. Our scroll bar that you see going down the screen right there has all of our information. perfweb.us, registered perfusioneducation.com, how to subscribe to our YouTube channel, how to do LinkedIn and Twitter and all that stuff. Make sure you like us, give us thumbs up, follow us, share us, all that kind of stuff. Our MediWeb app, do you have our MediWeb app?
No.
I'm very concerned about that, but it's on our, you can find it on the iTunes store, and you have 2 apps. You have the critical care application for perfusionists, but really it shouldn't be titled that because it's really good for ECMO specialists, critical care nurses, critical care docs, nurse practitioners, whomever, who would be dealing with perfusion-related things. And we have a second standalone app. And what's really cool about the critical care app is you've got perfusion quick calcs, like you're going in to do a case. You can put the patient's height, weight, starting hematocrit, things like that, and it'll spit out everything you need from your heparin dose to your predicted hematocrit after dilution from the bypass machine, you know, what your priming volume need is going to be, what your, you know, just various different things, that flow rates, everything that you need all in one. Just enter the data of the patient and it all calculates it for you and gives it to you. So that's really kind of cool. And there's within that a IV dose and rate calculator, and that's incorporated in the big app. It's only $2.99. You're going to have it before the end of the day. And exactly.
It's like you're going to download it for me.
And but anyway, and then there's a standalone IV dose rate calculator that you can get if you're a nurse in the critical care unit. It's very useful. All of our programs go over podcast, and you can listen to us on whatever your favorite podcast streaming software may be, and we'll go from there. Okay, so moving on from that, today we're going to be talking about transfusion thresholds and coagulation assessments of patients, specifically we're talking about the critical care unit, we're talking about ECMO. But first I want to introduce Kimberly Spurlin, who's been with our program before. You were the ICU manager at Memorial Hermann, the Woodlands Hospital. Where did you go to nursing school?
Originally started Tomball College and then went back to school for my BSN at UT Arlington and finished my MSN there.
That's right. And then now you're a nurse practitioner. Correct. Practicing at CHI St. Luke's and working in the CV service with Dr. Mark Mettauer.
Correct. And
you're doing assisting during surgery, harvesting vein endoscopically, and then also managing both the patients on the floor, the ECMO patients in the ICU, seeing clinics. So what do you think about the transition going from bedside nursing, critical care unit for many, many, many years, doing that level of care, and then also just management in the critical care unit, to your new role? How's that feel?
Love it.
You love it? Totally different.
Totally different, lots of autonomy. Great doc to work with.
Yes, absolutely. Well, I think you have to have that, right? You have to have the support of the whatever physician is your, I'm not sure what they
supervising.
Is that supervising physician, right? But really, I mean, you know, if you have to ask them everything, they have to trust you, and you have to trust that they support you, right?
Yes.
Because medicine is an imperfect art.
Always changing.
it's always changing, and you know, you do something, you choose to do X, but someone else who may be a physician would have chosen Y, but another physician who chose X, they may not criticize as quickly. Do you ever see that, and you know you have to have the backup support of your surgeon to say that was a very reasonable thing to do, or does that exist?
Absolutely.
Okay, so that does exist. And you think that's ego more than it is anything else?
A bit of ego, some of it different training backgrounds, experience levels.
And I think that's something that's another, and I apologize to everyone, I know I'm off topic here, but yeah, I find this very fascinating because I think you bring up a very good point, is there's a lot of really smart physicians who have never had to take care of a patient.
Correct.
But they're really smart people, and they get trained in a totally different way. Their core curriculum is a bit different, but they don't have that 10, 15 years of hands-on management of patients and seeing how so many different physicians manage the very same problem and gaining that experience as a critical care nurse and then transitioning to nurse practitioner. You know, both are very important, but I think both on their own merit are critically necessary, right? You have
Absolutely.
to have this academic, you know, well, the data, well, I don't, you know, from your perspective, well, I don't care what the data says. I know what my eyeballs say.
Yeah.
And so you have
Patients
that.
never read the books.
They don't. They don't. In fact, Sim Man over there, he hasn't read nothing yet. His eyes are open, but I don't think there's really any good communication connection. I think
Nobody home right now.
No, I don't think there's anybody there. But I'll bet if we put a cerebral oximetry on him, it would read something that would be indicative of life.
Yes.
So, you know, yeah, exactly. Patient or pumpkin. I don't know if you ever remember
Exactly.
that article. Do you remember that article I
Yes.
talked about once before? Okay, so several things that happen a lot when we're managing these critically ill patients, and you're going to see especially ECMO patients, which is sort of, I guess, where my focus may be, but just post-op cardiac patients who may be bleeding. You recently had one of those you brought back and found nothing that was actively bleeding, really, but there was still a lot of enough blood in the chest tubes to have to take the patient back to the operating room for re-exploration. But there are some very unique characteristics of managing transfusions when you're dealing with really sick patients in comparison to patients who may be younger, otherwise healthy, trauma, that they can overcome that with a much lower hematocrit than can somebody who's maybe 56, 57, doesn't really take very good care of themselves and now finds themselves in basically the fight of their life, or fight for their life. And where is the appropriate hematocrit for that? When do we transfuse red and yellow and platelets and all of that kind of stuff? I know there's an algorithm for mass transfusion, and we may not necessarily be talking about that, but there's definitely a system, a science behind it, and how do we measure it, and what are we really looking for, and what do we really want? So with that said, ECMO transfusion thresholds is the title of your talk. Yes, sir. Oh, hold on a second, guys. I need to share the iPad. How do I do that? I forgot. Mirroring. So I have to be on the main screen or the? Oh yeah, that's right. Okay, the little top edge. Thank you. And then it's that. Screen mirroring, and it goes to Joe's iMac? Correct. Joe's iMac. There. Oh, I clicked it twice. I'm sorry. Wait.
There it is.
It's working?
Yes.
Okay. And then back to this. There you go. We're good? We're good. Thank you.
Okay, so just a little discussion on ECMO transfusion thresholds. And there's not really a whole lot of hard and fast data out there that says exactly when you should put what kind of patients in which areas. So it is very patient dependent, very provider dependent, and makes it challenging when you go to have a discussion among providers, as when one wants to transfuse, one doesn't. And that's where experience comes into play in managing multiple different patient populations. So just a little information on critically ill ECMO patients, management concerns, obviously oxygen delivery, tissue perfusion, hemodynamic support, your circuit. Your goals of therapy are going to change where your thresholds are. Are you talking about a bridge to recovery versus bridge to transplant? Obviously, if you're considering transplant, you're going to go on your lower thresholds, and your patient bleeding risks.
So, do you want to talk a little bit about that? Can I sort of weave some stuff in here?
Absolutely.
Bridge to recover versus transplant. Okay, are you gonna elaborate on that, or can we elaborate on it now?
We can elaborate on it now.
Okay, so I think that's a very great point, because transfusions, though I am a lot more liberal, I want people to have oxygen delivery, and I want them to have oncotic pressure, and I want them to have buffer. But if they're going for transplant, how does transfusions affect that transplant recovery?
So they really want you to run on the lower threshold with them, just because all the immune mediator responses that you get, the potential for antibodies to form, is why they really want to minimize that and specifically run them on lower thresholds, letting them linger as low as 7 and staying there, and really holding off on transfusions, which makes it difficult when you're in the middle and you're still trying to decide, is this a recovery patient or is this a transplant patient? And you might miss that window on a recovery because you're running the lower ones, extend your vent days, induce all kinds of barotrauma, and now you've kind of backed yourself into a corner and you're going transplant. So that's kind of the tough challenge where, again, kind of provider experience, making a judgment call early on as to where you really feel like this patient is going and how aggressive you're going to be, and proactive versus reactive. Just like we've had multiple discussions with CRRT and initiating that early on, don't wait. And same thing with ECMO when you talk about putting patients on. Some of the providers that really want to hesitate and they see it as a last ditch. Well, if you're waiting till the last minute to put somebody on, you're obviously reducing your risk of success of coming off, right?
Well, yeah, your chances of success. Exactly.
Yeah.
Well, that's what we're doing right now.
Yeah.
Somebody that's been lingering since January, and I and no one wants to see anybody die, especially if they're younger. But
You have to be realistic.
I think
You lost the window.
I mean, 3 months ago or 4 months ago.
Yeah.
I mean, it was January.
Yeah.
Yeah, it's a problem. But anyway, with that said, I don't mean to belabor that point. Let me let you continue.
Okay.
That was good information, though, about the transplants, because I think that is a very real problem. And I think people somewhat underappreciate the immune-mediated response that we see when we give patients transfusions. That's not, there's some people that believe, and I think it's reasonable, that it is actually a tissue transplant, not just a benign transfusion that's only going to help the patient. There are definitely downsides to transfusions.
Absolutely.
But there's downsides to anemia.
Right. So just a little bit about threshold parameters. Definition-wise, restrictive runs 7 to 9. The kind of median is 8, and then they're calling liberal now 10 to 12. Risks and considerations associated with transfusions, obviously infection, your immune-mediated reactions, TACO, which is transfusion-associated circulatory overload, TRALI, the transfusion-related acute lung injury, your antibody formation, big consideration with all of the facilities now, regardless of patient population, is the cost associated with it And of course, availability. We just don't have the product available, and considering what patients to utilize it in versus just emptying the blood bank for nothing.
Yes, well, that's a very good point. And you know, we did a program with Vanderbilt yesterday, day 2. For those of you who may have watched yesterday as well, and I made the comment because they're doing now, you know, informatics and electronic charting and data collection, automated for bypass cases and ECMO cases, and that process alone, to have access to that data, is incredibly expensive, incredibly expensive. And, you know, for even a robust cardiac, community cardiac hospital like we have, 300 hearts a year, multiple ECMOs per year, is that really enough to really be meaningful when it comes to data, unless you're collecting that data from multiple sites and then
Sharing.
collating them all together and actually comparing a larger volume? Because you're, you know, it may be suggestive, but you're never going to reach an end that's going to be meaningful in, you know, without going through maybe 4 or 5 years. So it's a real challenge. How often does TRALI actually occur?
Not as often as I think people would like to say.
Yeah, I didn't think so. Unless you're doing, massive transfusions.
Yeah.
I think, but a single or double 1 or 2 units of packed cells. I mean, I've never really seen TRALI in a, couple 2 to 4 units of packed cells given over 2 to 3 days, or maybe on a perfusion case in the heart-lung machine where we give it there. I really haven't experienced
probably maybe 2-3 times, and that's taking cardiac patients, trauma patients, medical patients, broad spectrum, not just one specific patient population.
Right. Right.
More so like when you're initiating a massive transfusion, huge blood loss, and you're on round 3 to 4 of resuscitation, and again, lung injury versus your patient still there from lack of exsanguination.
Sure, and you're not filtering it anymore because you're just having to get it in, and those Paul filters really do slow down how fast you can get it in.
Yeah.
And when you're really trying to resuscitate someone and you're using the level 1, I rarely ever see a secondary blood filter. I know the blood bank does some filtering, but how much of that is just embolic versus the actual transfusion itself, I wonder. Sorry, go ahead. And cost.
Yeah.
We've been talking about blood transfusion mitigation for 20 years or longer.
Yep.
And it's always about this cost, and
it's a big thing with the hospitals now.
But it's been the big thing with the hospitals for 20 years, Kimberly. I've been listening to this same song and dance for 20 years.
Yeah.
And we really, how in 20 years have we not gotten to some place that we understand is where we are? I don't know what your view on it is, but that's, I've been doing perfusion, so I've been in a different realm than you for 40 plus years now. And I've listened to this. Whole companies have started off of transfusion reduction, blood management, they call it blood management strategies and programs and all that kind of thing. And, if somebody needs blood, they need blood.
Correct.
There's only so much you can do. You may be able to make an incremental change, but sometimes there's a flip side to the incremental change of withholding a transfusion from someone because they don't meet the criteria when they really needed it, and it may make a difference on that patient's outcome.
Anemia-related hypoxia leading to end organ damage. So you let somebody be anemic, their AKI, now we're acute renal failure on top of it, end up on CRRT, dialysis. What's the cost of that compared to treating ahead of time?
Blood. Yeah. We didn't give them blood. We saved 1 unit of blood.
Yeah.
Isn't that fantastic? Yeah,
1 unit of blood, and now we're here.
But then if 1 unit of blood makes the difference, is that patient really, not going to have that problem anyway? Don't have an answer to that. I don't know. It's just a provocative thought. And you're right. The lower your hematocrit, the harder and faster your heart has to beat. And that can be consequential if you have somebody who has some heart failure or ischemia or whatever the case may be.
Absolutely. I mean, it's such a thing. Currently where I work, we have to justify every transfusion that we give, especially on our post-op cabbage patients now. If we give any product at all, we have to notify the CMO and tell them why we gave the product.
I mean, that's, okay. Well, it is what it is.
It is. The challenges.
There's challenges. There's no question about that.
So just a little bit about appropriate restrictive patient population considerations of patients that fall into that. Your sepsis patients, ARDS, we talk about COVID. COVID initially, of course, we had all those older patients when it first started, and then it went towards the younger patients who, not a whole lot of comorbidities. Obviously, we could let them linger. They could handle anemia better. They could handle tachycardia better. Initially, they can handle hypoxia better, and then they get so sick that they can't. Looking at that and considering that specific patient population. Renal failure patients who, especially chronic renal failure patients who are used to a chronic state of anemia. Obviously, you can put them in that restrictive box or bubble, and they're going to tolerate it a lot better.
But I got a question for you, and I'm sorry, I didn't mean to interrupt you, but you're saying that septic patients and ARDS patients are appropriate to restrict and to have a lower transfusion threshold?
Early on. If you think early on and you're trying to think long-term, turn them around, get them off the ventilator quicker, reduce those days, reducing minute ventilation by not volume overloading, stuff like that is where I'm saying those patients initially fall into that restrictive patient population.
To me, it's counterintuitive to include sepsis in that because you want a higher DO2 or DO2I on those patients. And so, the lower the hematocrit, the lower your DO2, given whatever your cardiac output is, you're just going to have to go up a lot higher. But yeah, I don't know.
Early on ARDS very different than later ARDS. What are their peak airway pressures? What can they tolerate? And that's where they kind of rotate back and forth. They go out of that restrictive to now we're in, the more liberal, again, looking at everything else going on with your patient.
Yeah. We do tolerate a lot. And patients tolerate a lot, not just the ECMO patients, but the heart patients. We go on bypass and our hematocrit goes from 34 to 26 in the matter of just a few seconds. And what effect does that have on a whole variety of things? That's your fluid shifts and all of that stuff. I do think that, again, after all these years, I think we've made some incredible advancements in medicine, but I also think that some things that are so significant in that affect outcomes, we've not done very well with.
Yeah. Some appropriate liberal patient population patients, obviously ischemic heart disease. Brain injured patient, trauma patient for the obvious, bleeding patient requires blood. You don't fix a bleeding patient with pressors. Same thing with, your post-op cardiac patient. Again, they're going to be, if they're losing blood into their chest tubes, then fix your coagulopathy and replace your volume. It's not vasopressors.
But you can't fix the coagulopathy if you don't have the red cells, to fix the because you don't have a circulation then. So it's very complex. I want to know more about. I'm going to let you finish because I want to know more about the process and how we measure it and how we calculate what we're giving when we need to give patients not just red blood cells for oxygen carrying capacity, but also plasma, cryo, platelets, etc. So I'm going to be very interested in that portion of this.
Okay.
Or the next paper or next slides.
So benefits of higher transfusion thresholds, reduction of risk of anemic hypoxia, reduction of minute ventilation and work of breathing, reduce your prolonged time on the ventilator, and reduce overall length of stay. So obviously, when trying to push this from the hospital administrative side and justifying why you're giving, hitting the big points of reducing ventilator days and overall length of stay, they'll kind of turn another ear towards you instead of giving you pushback.
But there are people and articles that there is data. There are published peer-reviewed articles that would argue giving the transfusion prolongs your time on the ventilator. But there's articles that having too low a hematocrit and not giving transfusions. There's a lot of contradictory data out there. This is not settled science by any stretch of the imagination.
Absolutely not.
And it may be because you and I, though both human, are very different physiologically and otherwise.
Yeah.
Unless I just choose to identify differently today. Not that I will, but I could. It's okay today, right? It's okay. I can identify as whatever I want. So there is, you do agree, and I'll ask you if you disagree, please speak up. But not that you wouldn't. That there is contradictory data out there about ventilatory time, transfusions, or non-transfusions.
Have a patient that we're managing right now on that's on ECMO, and again, management early on, we kind of missed a window of bridge to recovery, and now we're going down that transplant road. So lung rest early on, give him aggressive carrying capacity. Could we have gotten him off sooner and not landed where we're at now?
I don't know, and I think that's another topic that is so complex, and that is who is going to recover and who is not. And I'm talking about organ recovery. So whose lungs will recover? And what does that really look like? And what does it mean? How are we defining it? And who won't recover? I don't know if this guy's lungs were ever going. I think we could have gotten him off ECMO, but his quality of life, I think, would have been horrifying. I think we could have gotten him off, and that would have been declared a success. But
it's how bad of a pulmonary cripple he was going to be.
Right. If his if his lungs are non-recoverable, but of course, you get a priority if you're on ECMO for transplant. If he got off and he was just miserable, where does he fall on the list? And there's an organ shortage. I mean, there's just not you can't go to Walmart and pick out a pair of lungs. It doesn't work that way. Or order them from Amazon Prime.
That's what the public thinks.
It is what they think, and there's a real shortage of organs, and they're challenging to take out and transport from point A to point B. And then how many transfusions did this guy get, and how is that going to affect his matching of an organ? Logically, there's a lot to unpack, and we could talk about this. Vicky today, my wife Vicky, she asked me today, You know, why do you always talk about ECMO? You guys just need to talk about something else besides ECMO. And I don't think that most people not in this business that, and she's anesthesia, but she's an anesthetist, so she does that, but you know, not with ECMO patients. That we could talk about ECMO for the rest of this year, 24/7, and still not completely understand all of it. It's a complex topic, and this is a section of it. It's related to ECMO, but transfusion management is just one little teeny piece of a big giant puzzle. You know, I don't think a lot of people understand that.
Yeah.
Organ procurement, that's another part of this that makes it very complex. Please.
Well, talking about different patients, you know, and managing them and considering comorbidities, that's where reduction risk of anemic hypoxia comes into play. So again, you have a young patient, 0 comorbidities, gets the flu or COVID, ends up on ECMO, and you know, you can let them obviously have a little lower carrying capacity and they might do okay versus obviously your cardiac patient who
Failure to wean.
yeah, they are not going to come off.
No, I agree.
You have to be aggressive with them. And that's where it's tough provider to provider, because you have some people that, you know, all the new literature reducing this, and so they take one little piece of that and don't have the experience of managing a multitude of patients and seeing long term where they go and having that discussion as to this is why I'm advocating for this, and getting, you know, somebody on board with you is kind of the challenge that we face even with our facility.
Understood. Yes, it is an issue. Is that your last slide? Okay, good. So we can go to the next topic, which I think is going to be, you know, these are dovetailing together, obviously. So we go up this way. No, we close this. Okay, and then I go here, and it was ECMO transfusion threshold. No,
Anticoagulation.
it was anticoagulation. Let's see. Hold on. Oh, I know where it is. Okay, here it is. There you go. And then presenter view. Bingo.
Okay,
Dude, I'm getting good at this.
you are.
I am.
So, just a little bit about anticoagulation management. Varies by facility, both what they're using, how they're testing. So just hemostasis disruption. Obviously, as soon as you expose blood to a foreign surface, you immediately stimulate inflammation and coagulation, which then leads to a prothrombotic state. Two most common complications with ECMO are bleeding and thrombosis. Our goal needs to be to prevent thrombosis in a patient and in the ECMO system while balancing and preventing a lethal or catastrophic bleeding event.
We saw lots of all of this. And I never really knew who was going to do what. We did 0 anticoagulation heparin, ECMO.
ECMO, yeah.
We did platelet inhibitor ECMO. We did factor 10A inhibitor ECMO. We've done unfractionated heparin ECMO. We've done Lovenox ECMO. We've tried it all.
But we couldn't compare any one of the different groups because it was specifically talking about COVID patients and managing them, because it was different variants that reacted differently.
Yeah.
You know?
Who was going to be prothrombotic?
Exactly.
Who was going to react in that way?
Yeah.
And who wasn't?
Yeah.
And then we had the patients who were no anticoagulation, basically running, you know, a subtherapeutic PTT, but no problems with any clotting at all. The ECMO circuit, because we were able to measure oxygenator blood volume, we weren't having any circuit issues. And then they would have a massive cerebral hemorrhage and just die.
Yeah, we had 3 of those? 3
Yeah.
or 4?
A lot.
Yeah.
I'm going to talk a little bit about that.
Okay. So your goal of anticoagulation with ECMO, find the desired dose of appropriate anticoagulation to maintain circuit patency by preventing thrombus formation while minimizing the risk of bleeding in your patient. So again, balancing that with what's your underlying disease process and what that patient can handle. They call it practicing medicine for a reason.
No kidding.
Types of anticoagulants used: heparin, bivalirudin, and argatroban. At our facility, heparin is the first go-to, obviously, unless there's, a history of hip positive because of the cost associated with the other two. Heparin, the most commonly used anticoagulant used for both children and adults. I don't practice with children, so I can't speak about that, just adults. Heparin potentiates antithrombin 3, resulting in an inhibition of thrombin and factor Xa. Levels can be easily monitored and titrated following serial PTTs, and heparin has a relatively short half-life of 60 to 90 minutes in patients with normal kidney function and 3 hours in patients with renal insufficiency. Obviously, especially in my area that I work in, very useful when you have to take somebody back emergently or scheduled to go for surgery. Heparin can be easily reversed with protamine, and monitoring methods include ACT, PTT, and antifactor Xa. When I worked at Herman, we had in-house monitoring of antifactor Xa, which was really nice. Don't have that capability in-house. Where I'm currently at, we have to send it out. So we use ACTs and PTTs.
We rarely ever do ACT. Well, ACTs in the operative room.
Yeah, in the OR.
But for ECMO, you remember the days when we would do an ACT every hour? Mm-hmm. And of course, the low range ACT is very unreliable and has a wide variation, a wide margin of error. And then we eventually, now we just do PTTs, and I haven't done an ACT on an ECMO patient in 5 years, at least.
In the ICU.
In the ICU.
Yeah.
Yeah, in the operating room for bypass surgery is a totally different thing.
Right.
But those are not low-range ACTs. When you're looking at ACTs, basically normal is going to be, if it's 118 seconds, it's probably going to be 118 seconds if you run serial 3 or 4 times. If it's 480 or 520, it's probably going to be somewhere between 480 and 520 if you ran the same test 3 or 4 times. Mm-hmm. But if you run an ACT that's 180 or 190 in that range, 180 to 200, it's going to vary all the way from 120 seconds to 300 seconds because that low range ACT has never been able to, it's just not an accurate test. Mm-hmm. And PTT has just been shown to be so superior in that range versus ACT, and that's why it became the preferred method. We just stopped doing it because ACTs, we were all over the map, giving heparin, stop holding the heparin, not giving it, and it was back and forth.
Did you get your little drop out? Did you get the air out? Did you,
and
overfill your cassette? And,
right. Yeah. And technique is a huge part, especially again when you're dealing with a low range ACT. Mm-hmm. Normal and a full anticoagulation. Fully anticoagulated ACT is going to be, it's either fully anticoagulated, and there's no difference between an ACT of 480 and an ACT of 700. There's virtually, it's fully anticoagulated. Mm-hmm. That's all. That's really what you're looking for.
Yeah. Just a little bit on bivalirudin. It's a direct thrombin inhibitor. Can be utilized for patients who have a current or previous history of HIT or heparin resistance. Has been used safely in adults, but has very limited data available for use in neonates or pediatric patients. Again, I don't deal with children, so that's just a little bit of research that I was doing to include for the wide variety of people that might be tuning in. Monitoring methods include ACT and PTT. The half-life is 25 minutes in patients with normal kidney function and 50 minutes in patients with severe renal impairment. There's no reversal antidote, and it can be used safely in patients with hepatic and renal insufficiencies. Then argatroban, direct thrombin inhibitor, can be utilized for patients who have again, current or previous history of HIT or heparin resistance. And I think this is just facility dependent, what they have, and then lately probably resource dependent as to what's currently on shortage and not, which changes every other week. Has been safely used in adults and is the first pediatric labeled safe choice for patients with HIT. Monitoring methods, again, ACT and PTT, half-life of 45 minutes, no reversal antidote for this one either, and it does have to be dose adjusted for your hepatic patients. Traditional ECMO anticoagulation ranges, PTT 1.5 to 2.5 times the baseline or 50 to 70 seconds. ACT 160 to 180 for bleeding patients or 180 to 220 for non-bleeding patients. And then a anti-10A if you're utilizing that of 0.3 to 0.7. Would you agree? I saw the head bob.
Well, yes, I agree with the PTT, not necessarily up to 2.5 times the baseline. I think that's too high. I think 1.5 times baseline is more than enough, and I think up to 2.5 times baseline gets a little high, especially, you know, I mean, I think the cannulas tend to bleed a little more, cannula site skin, anything like that. So I don't quite like to see it that high. The ACT 160 to 180, again, I don't use ACT on low range, so to say your ACT is 160 or 220 you know, there's no way to know it's really 160 or it's 220. It's too much variability, and it doesn't work very well. As far as the anti-10A, I think, you know, around 0.3, 0.4 is reasonable. I think 0.7's too high. That's my view.
Okay.
What say you?
I like the lower range if the patient can tolerate it, obviously.
Yeah, if you're not getting clot, but I mean, you won't. You know, it's funny thing about the ECMO. You put somebody on ECMO, and I think your point, your first slide was very important, very, very important. You're going to have interaction between the patient and the ECMO circuit. And there's going to be an immune response. Certainly the circuit is thrombogenic, but of course the circuits we use, they have the oxygenator fibers, but they don't have, like in the operating room, an arterial line filter incorporated in it, which is something that is increases the thrombogenicity significantly. And if you have, you know, a lower range on that, and you're flowing a good high flow, and your transit time through the oxygenator, and your oxygenator is designed well where you have good washout, and you don't have areas of stasis in various parts of the oxygenator, so well-designed circuit is important as well. I just don't have problems. When your flow gets low, that's a whole different can of worms. So if you're on VA ECMO and you're trying to wean the patient by reducing your RPMs and your flow, which we'll talk about maybe later or show later, then your transit time through the circuit much longer, you have to raise it up. VV ECMO, on the other hand, you don't have to reduce your flow. In fact, you shouldn't reduce the flow, so you don't have to further anticoagulate that patient. You just simply keep reducing your sweep gas and your FiO2 until you can disconnect it. And then you just basically have nothing but a loop circuit in the right atrium. You're pulling and returning, and it's a closed circuit, so you have no volume changes. It's the same. What's going in is coming out. What's coming out is going in, all at the same time.
Yeah. And, you know, we saw it with our patient that's currently on now, day 35, 37. when
No, this is day 45. Oh,
no, 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 no,
during
no.
day.
During day, it was either 35 or 37
Okay,
that we
'cause he's
changed
on
his
day 50
cannula.
today.
Correct. But when we changed his
Yes.
cannula and then had to change his entire circuit, and we saw he was a little bit delayed. It was like at 48 hours that he had that big SIRS response, blossomed everything out.
Yes.
That we kind of expected in the first 24 hours, but again, he didn't read the book and he did it at 48 hours.
Right. So you did see an inflammatory surge, a sort of a systemic inflammatory response that was not maybe severe, but it was, it wasn't severe SIRS, but it was obvious.
Yes, absolutely. So had to have that discussion with both infectious disease and Palm Critical Care, who saw the x-ray, his white cell count, all of that, went panicking. Let's take out all these line vacation, all these cultures, do this, do that. I'm like, look at his oxygenation, look at everything else. Look what we did in the last 48 hours that can explain that. And
Yes.
again, that's where, stepping back, looking at what's going on with your patient and not just reacting to that x-ray, oh my God, what's going on with that? Or look at that WBC count.
And for those who may not know, though I assume most do, but just for their benefit, when you initiate ECMO, that inflammatory process, the lungs that were looking like they were improving will get whited out again. So you'll see, basically a very fuzzy image on your X-ray, wet lungs,
Yep.
and you're going to see an elevation in your white count, sometimes quite significantly, but it's transient, and it
Right.
comes down on its own without the need for further antibiotic therapy.
Correct.
So you have to know that so that you don't react and treat it. But then on the other hand, if it is something else, you need to be treating it.
Correct.
So you have to sort of there's that judgment part of this whole thing again.
Yeah.
And you believe you're making the right decision, but there's always that chance it wasn't the right decision, and we don't know that until we get there.
Yeah.
We never know what's around the corner until we've gotten around the corner. We have no way of seeing.
Right. ACT, inexpensive point of care, readily available test that reflects time of clot formation via the intrinsic coagulation pathway. Again, especially low range ones that are sitting in ICU, depending on if lab's QCing or nursing is QCing, kind of saw that as a challenge at a facility that I worked at, because there wasn't a whole lot of consistency on who's doing the QC, is it getting expired, and then you're doing a QC when you need to do a test, and that is a little bit of a challenge, especially with the low range ones that aren't utilized as frequently. And we saw, it wasn't a low cost thing when you have nurses doing it that don't often do the ACTs, and they get error messages, and 6 cassettes later, it's obviously not very cost efficient versus we tried to kind of enforce, here's our super users, by getting a handful of nurses checked off that could consistently do this. Well, then what happens when they're on vacation? And trying to accommodate that in a schedule is very difficult. So that's kind of a drawback of that.
It's very easy to take 2.5 cc's, put it in a blue top tube, send it to the lab, and get a result. What do I always tell Danny over at St. Luke's when we draw any sample for any reason? Send it to the lab.
Send it to the lab.
Send it to the lab. I'm not a big point of care testing kind of guy. I think that there's some utility to it, but I think that it makes more sense to have all of that and have the infrastructure to be able to get it to them quickly and get a result quickly, as opposed to trying to get people in the operating, especially when you're trying to take care of a patient and things are really hectic and you need a lab. That's what they're for. But of course, it's, I guess, not cost effective.
Yeah.
Yeah. It's easier to have us do it, but I don't think I don't like it. ACT, I think you need to do that when you're on bypass. You can do that.
Yeah.
Maybe a
Bypass,
blood
cath
gas.
lab.
But then
Yeah.
you talk about different point of care devices. Doesn't matter whether you talk about the iStat or you talk about the EPOC, and you know, both are you know, they work, but they do not work for hemoglobin. Anything that is electrical impedance is not going to be very accurate with hemoglobin. So you have to have these various different algorithms in place to, am I on bypass? Well, no, I'm not on bypass, but the patient's hemodiluted. So I think I have to pick them on bypass. So you have to put that on there. And then it calculates, it takes that into consideration that a hemodiluted sample, when you use point of care devices that use electrical impedance and not co-oximetry, cannot accurately read the hemoglobin without the particular algorithm, and that can be very off. So you can transfuse, you can have a very low hematocrit, but it's not that low, or you could have a very high hematocrit comparatively, and it's not that high, and you don't know. That's why I send it to the lab.
Again, utilized immediately, OR, ICU, cath lab, frequently used initially, then serial monitoring and titration is done using PTTs. Results can be altered in patients who are hemodilutional or hypothermic.
Yes, absolutely makes a big, the ACT, hemodiluted ACT, you know, very diluted blood doesn't clot as easily, and hypothermic and cold blood don't clot, right?
Right, absolutely.
Cold blood don't clot.
PTT, used to measure the clotting factors of the intrinsic and common pathways of the clotting cascade by measuring the time in seconds it takes to form, it takes a clot to form. Typically the standard for monitoring and titrating anticoagulation therapy for heparin, bivalirudin, and argatroban. It is not a point of care test run at the bedside, but is resulted typically within 30 to 40 minutes from lab. That's obviously going to vary greatly by facility. Time of day, staff in the lab. So for patients that are on ECMO in little community setting hospitals that have skeleton crews, obviously you've got to put something in place so that you're ensuring that they're getting the same standard of care as...
Should they be doing ECMO? That's another question.
So when you get backed into a corner and you don't have a choice, and maybe like we saw this with COVID where there were just no beds. So does somebody in the middle of nowhere deserve to not have a chance for recovery, and you leave them there until you can get them to the appropriate facility? Yes. Should they be there for a prolonged period of time and let it be a standard of care and let people practice? No.
Well, I'm going to say something that's probably going to seem very harsh. And, you know, it's certainly provocative. But if you use that approach, then, and you consider the cost to the system, and I'm not talking about that individual hospital, but just the system, and the chance of recovery, if you put somebody in a small community hospital on ECMO and leave them there until you could get them transferred, if you can ever get them transferred, and the chance of that person recovering, I think that the cost to the system and the risk and the loss of ability to service other patients with other problems that are more easily resolved or have a higher chance of recovery, and they get pushed to the side for this particular patient, I think is I don't agree with it. I don't want to see people die, but unfortunately we do. Car accidents happen every day. People get cancer. We have wars. We have terrorists. We have just crazy accidents that happen. And that, unfortunately, is life. And there is just no way. And I think, too, you know, not only did we see And this is data that is actually it's going to be published here in the U.S. as well, but it's originated in England. They looked at all-cause mortality other than COVID. So they isolated anything COVID out and looked at all other cause mortality. And there was a quadrupling, fourfold increase in all other cause mortality during COVID because so many of these patients had no access or could not get access, appropriate access to health care. So yes, everyone deserves an opportunity. I agree with that 100%. But for everyone that gets that opportunity, who doesn't get an opportunity, and how do we as a society choose which one to help? The one that is in front of us right now, or the one that we predictably know is on their way?
Isn't this why you're doing this, though? Wide population cover, maybe those people that are practicing in smaller communities, they have this as a resource, can reach out, educate themselves, collaborate.
But you're still going to consume a tremendous amount of resources. You're going to have to stop doing that. They don't have the infrastructure to manage that patient and still take care of the other patients that they have, because ECMO is not just a peripheral IV with D5W at KVO. Right? It's a tremendous, it's a highly resource taxing process and takes multidisciplinary involvement and can burn your blood bank out in a matter of minutes, okay, if not hours, but minutes possibly, just that fast with an event. Should everyone be doing ECMO? And I question it. I do. I question it because I just think that it I don't know the answer. I mean, maybe we should. Maybe we should be pushing and expanding this to make it so that it's like just doing CRRT. But because I think CRRT is still considered voodoo. It's like, oh my God, we're going to put somebody on CRRT. It's like we're doing a transplant, a 5-organ transplant, okay? But it's not. And maybe ECMO needs to get to that point. I don't think we're anywhere near that yet. No. But, I mean, that's the comparison that I could possibly give here. I'm sorry, go ahead. Oh. I sound very anti-ECMO today, don't I?
You do.
And we got Sim Man. We're going to have fun with ECMO, because I love ECMO. I just don't know that everybody should be doing it, including me sometimes. Go ahead, I'm sorry.
The anti-factor 10A assay is designed to measure plasma heparin, including unfractionated heparin and low molecular weight heparin levels. There are therapeutic ranges and prophylactic ranges. Therapeutic ranges for heparin are 0.3 to 0.7, and for low molecular weight heparin are 0.5 to 1.2. And then prophylactic ranges for heparin are 0.1 to 0.4, and low molecular weight are 0.2 to 0.5. Typically run in addition to a PTT, but they do take longer to result. Effective tool for patients with suspected heparin resistance. I know we used anti-10As, my previous doc that I worked with trauma patients, especially for our low molecular weight, is kind of how we decided on keeping, adjusting their prophylaxis dose while minimizing their risk for bleeding. Obviously, these pelvis patients, femur, hips, polytrauma patients, very useful tool in managing those types of patients.
Yeah, you really have to worry about DVT in those patients. I mean, that's really your problem.
Yeah. Monitoring when initiating therapy. In the OR, ICU, ACT can be utilized immediately as a bedside point of care, but then typically transition over to a PTT, monitor every 2 hours until a target goal is reached, and then you continue to monitor every 4 to 6 hours per your hospital protocol. Once you get, there's different therapeutic ranges for different therapy modalities. If at any point you have to stop your anticoagulation, then you resume your frequent monitoring every 2 hours until you're therapeutic, and then may resume every 4 to 6 hours per your hospital protocol or per your protocol, like we were talking about a couple days ago.
Exactly. Yes. Well, we could talk about that. Although I have to admit it worked out, so I can't really say anything. I told, what was her name? Was it Sarah? No, it wasn't Sarah. It was Amanda. I told Amanda, I said, that PTT isn't going to be anywhere near that, with doing it that way. But it ended up being exactly where they wanted it to be. So I was a little bit upset about that. But, I just don't like to go, like the heparin, let's say, is running at 800. And your PTT drops to, it's been running between 46 and 50 for the past 3 days, and it drops down to 39. So they'll turn the
Drip rate
up. And I would, because it's been so stable and just finally sort of dropped off, I would just give like a bolus of 500 units or 1,000 units to move it back up again, depending on the size of the patient, move it back up again, and then watch it for a while to see what it does instead of going up on the drip, because that might just be too much. Then you go up, then you have to come back down again, and you're basically just roller coastering. And that's just not how I was taught to do it. And so I'm more comfortable with giving just a bolt, unless it's a dramatic change and you have to do both.
Right.
But what do you think? What do you think works better? Though it worked great, okay, I have to admit, they did the drip and it was perfect.
I'm a fan of bolus, but again, been doing this 20 plus years.
It's age-related boluses.
Yes, age-related boluses.
Yeah.
And finding that happy medium that comes with experience, but then you kind of have to have something in place for your new nurses that, says hard and fast, here's where you can go. This is proven to be safe, because they haven't figured out, just like with titrating drips, whether it's sedation or vasopressors, comes with experience.
Well, and that's, and just as my anecdotes, I always like to have, but you cannot read experience.
Yeah.
You just have to live it. And you have to stay in this industry long enough and stay in that role long enough in order to gain that experience. The only way to get experience is to experience it.
Correct.
That's it. There's no other way to do it.
Yeah, can't read about it.
Can't hear about it, can't listen about it. You have to actually do it. And that's why it's so important for people that get into medicine at any level, stay in it to be good at what they do. It doesn't matter who you are or what you do. Look at these guys that are the astronauts and stuff. I mean, they are in that industry, fighter pilots and then test pilots or whatever, and then they're astronauts, but they stay in that industry for decades before they get that chance that they've been looking for all that time. They don't ever you don't come off the street and become an astronaut.
Right.
There's a long road that you have to do to be good at that. And you can do any industry. It doesn't matter what. Chefs, they have to experiment. They have to try. They have to experience. They have to just do and see what does or doesn't work, and that's how you do it. Medicine is no different.
Absolutely. I would tell new grads coming into the ICU especially, I'm like, you're a nurse working in the ICU right now. You're not really an ICU nurse till you've got a good 2-3 years under your belt. Then you can call yourself an ICU nurse.
Exactly.
And it would offend some people, but it's just the truth.
Yeah, when you have the comfort to pause a powerful vasoconstrictor or take it out of the IMED pump or the IVAC, I used to call it, I remember the original IVACs, and just open it up and let it run for a bit and then close it back again. Until you have the comfort to do that, I agree with you. You're not either, perfusionist, if you don't have the confidence to do this, and you have to look at an algorithm to make every decision that you make, and what does the protocol say? If everything has to be followed the protocol, then you aren't a perfusionist.
Yeah. And you have to, whether you're a perfusionist, nurse, physician, critical thinking skills have to be built with time and experience. You can't just read a book and be able to process that real time.
Or read the protocol.
Yeah.
What am I supposed to do here?
Yeah, exactly.
While the patient's dying. Okay, step one.
Phone a friend. Additional lab studies to monitor. Careful attention to CBC with trending of your hemoglobin and hematocrit and platelet count. Daily CMP to monitor and trend renal and hepatic function. Daily fibrinogen. Plasma-free hemoglobin or LDH if hemolysis is suspected. And if coagulopathy is suspected, then you can also utilize a rapid TEG to assess platelet function, clot strength, and fibrinolysis. Not all facilities have access to the TEG. We're experiencing that challenge.
Really? Oh, okay.
We don't.
I didn't realize that. I mean, it's such a useful tool, and it's been around also. TEG has been around for a long, long time. Now it's gotten so easy and simplified. The technology itself has become very easy to run compared to what it used to be, where it was very, technique dependent, and you had to put it in there, the little needle would be moving around. You had to be very careful with running it. And when I first saw it, I was thinking to myself, this is ridiculous. But now it's very easy to run, and it gives you such useful information.
Absolutely. When somebody wants to talk about blood conservation, again, is your facility utilizing TEG? Or are you guessing what the patient needs, emptying out the blood bank and hoping you're right?
222. I mean, just because that's what you have to do. You don't know what it is. 222 in a 10-pack.
Yeah.
Yeah, that's what you're doing. And I think having platelet mapping, very important. Knowing what the platelet function is, and it can help you tremendously to identify prolinemia or coagulopathy.
Yep.
This patient is bleeding and the TEG is normal. There is a surgical bleeding problem.
Right.
This needs to go back to the operating room, and you don't wait until you've bled 3.5 liters and replaced it thinking it's coagulopathy. It gives you your answer, which is this.
Yeah.
But if you wait long enough, then it's both.
Yeah.
Now you have surgical bleeding and a coagulopathy.
Yep.
And then you're really problems.
Nursing considerations: minimize unnecessary blood draws, trickle feed these patients early on to minimize gut irritation and reduce risk for GI bleeding, utilize PPIs, which hopefully everybody is using in their facilities as bundles.
What are PPIs?
Proton pump inhibitors.
Oh, okay.
Collaborate with the physician and the perfusion team to maintain the lowest possible threshold, especially if you foresee the patient is going to require an extended period of time on therapy. Again, collaboration with the entire team is really important. It's not just nursing responsibility. Maintain platelet count thresholds greater than 20,000 in non-bleeding patients and greater than 50,000 in bleeding patients.
Man, that's low. Is that real? I mean, would we ever do that? I would never do that. Would we? I mean, would we do that?
Mine, I keep a little higher, but if you're talking minimizing product utilization, all of that, you can safely go to there.
Man, that'd be scary to have a non-bleeding ECMO patient with a platelet count of 25,000. I would be freaking out. I'd be very good. That would not. I wouldn't be able to rest with that. I wouldn't.
Monitor, see what they're doing. Are they oozing, not oozing? What's causing their platelet dysfunction?
Their thrombocytopenia. Heparin.
Yeah.
It's hits.
Maintain a hemoglobin and hematocrit threshold as directed by your physician, and maintain normothermia in your patient. One of those that's really not looked at enough. surgical patients, trauma patients, elderly, zero body mass patients. People really underestimate what hypothermia does to
They
your
do.
patients.
They do. I agree with that 100%. You know, we've said it before. We said it earlier. It's a little cute anecdote. Cold blood don't clot. And I think that for my perfusion colleagues out there, and also your colleague nurses in the critical care unit, when we come, you know, the surgeons, they want to get done with the case. And if we cool a patient down below 28 degrees or lower, and even 30 degrees or lower, and we don't rewarm long enough, looks like we're warm, but we really aren't. And then the operating room is cold because they don't want to be hot. And then the patient gets cold again, and then we go to the ICU and they hook them up and they're 35.4 and they're cold, and sometimes even lower than that. So then they start shivering. And if they do have any coagulopathic tendency, it's going to exacerbate it tremendously. Now, if you have a neurologic injury and you need to stay colder for a reason, that's a different situation. But absent a neurologic reason, we really don't warm our patients long enough. Not necessarily make them hotter, but keep them warm longer to get all of the, all of the deep tissue, the muscle, the fat, everything homogeneously normothermic before we terminate bypass. I think they're in a hurry. They want to get done. They want to close. They want to go. And I think that's, especially if we use profound hypothermia, circulatory arrest, you really have to spend time warming that patient. You really need to spend time cooling them to make sure you're cold and stay cold. You have rebound warming while you're in the middle of the procedure. But if you use selective cerebral perfusion, you can get away with that a little bit easier, really. And you don't really have to go as cold. But if you do use deep hypothermia, you really need to spend a lot of time warming that patient to make sure it's homogeneous, or you are going to bleed significantly.
Yeah. That's my last one.
Oh, that was your last slide? Oh, good. Well, good. That was good. Anybody, we got the phone lines open? Nobody's calling in. I don't see it on the thing. I don't see phone lines open. Oh, there it is. I see it. Okay, good. Very good. Those are both excellent. And you threw these together pretty quick. Look, your email just came through.
Oh. Small delay.
Okay. I need just a second to change the slides over. Do you want to put an overlay? And maybe we could take, can we take a 2-minute break? Would that be possible? Sure. Yeah, because I have to swap the slides over, and nobody online wants to just watch me doing this. So maybe do an overlay. Kimberly can get a new coffee. I can grab a new coffee, and then I'll come back and we'll do my slides. See you in just a minute, everybody. Don't be gone long. Thank you. Okay, welcome back, everyone. I'm just going to jump right into my lecture, which is going to be, the title of it is, I have to look and find it here. Yeah. Angiovac for large thrombus in the RV, integration of an oxygenator for bailout maneuver. And this is something that's been thought of before, and my slide actually was originally done by Min Tran. And you've met him before. He's been on several programs, was just on one recently the other day. But I added a few things to it, and we can go over this as we go. So I will admit that angiovac, I love angiovac cases. They're fun cases. And, sorry, forgive me. So, and they're so, you get an instant gratification. That's what I like so much about it. But anyway, we'll move forward here. So here's a video, and what you're going to see is this large ball, and I think I can highlight it here. And this is actually one of our cases. This is Dr. Mettauer. This large ball flopping down through the tricuspid into the RV and then bouncing back up. It's never really leaving, but it's scary, right? Yeah. It is. And this next image is in the operating room, and this next video, I'll show you this one, and there you can see it again. Same exact thing. Now, we couldn't appreciate it at the time, but knowing how it came out, what it looked like, it's really almost, it looks like it's all flopping down there, but it's unraveling. It's almost like a coil. Very interesting case. But anyway, if that thing were to break loose, as you could well imagine, and just go out to the PA, that's going to be a saddle block embolus. That is probably going to be a dead patient.
Real quick.
Right. So how do we prepare for that? Because the angiovac, for those of you who may not be familiar with it, is, you know, I probably should have had an image of the actual angiovac, but it basically is an access, which is what's going to actually suck the clot out. And then it goes into a filter, and through the filter into a pump, which is generating the negative pressure, and then there's a return that goes right back to the patient. And that's all the system is. It's for removing unwanted intravascular material. The question is, how do you remove this, and with the fear that you may not capture it but knock it off, and then you are going to go into right heart failure, you have BE, and you're going to have a bad outcome. So it's been thought of before, this concern, and I'll show you how they handled it, and then I'll show you how we handled it. But you know, obviously, acute pulmonary embolus can be devastating, immediate RV failure. Clearly, you're going to become very hypoxic, anoxic. You'll have very reduced, if not absent, systemic perfusion, and ultimately death. It's what we've been talking about, right? So this article was written in the Journal of American College of Cardiology, and it shows the unique case of venous thromboembolism treated with the angiovac system, and it gives information about the patient. But you can see down here the actual thrombus that was removed, and you can see their image. You know, their pre-TE, their TE pre-aspiration looks very similar to ours, really. And then post, you can see that it's all nice and clear now. And the rationale for this technique then was written up in the Journal of Extracorporeal Technology in 2017. Here are the authors here. And what they did was they have their access, so they were going to so you can choose, let's say it's venous, you can come from superior, you can come from inferior, depending on where the unwanted intravascular material is located and how the cannula will work. Now, there are new generation cannulas have the ability to have a 180-degree turn. So you can come in to the IJ, go into the RV, through the atrium, through the tricuspid, into the RV, and turn it all the way back up and go into the pulmonary artery with this thing. So it's pretty impressive, their new generation. But very quickly, they're accessing here in the neck, coming superiorly, and then you would have a clamp here. It's going down this way into the Angiovac filter, into the pump, and then it's going into an oxygenator here. Their system, I kind of get it, but I don't really get it. And of course, this reservoir, this is if you're going to do a sternotomy. I think that for a bailout, where you just need to get the patient supported, this is a big problem when you do this. It's very hard to move the patient if you're in the cath lab, or you're in the operating room, or you're in the hybrid room. What are your plans to do with the patient? So this is an interesting technique, but in all frankness, it is not what I would do. But it was written in 2017, and I think that the idea that if we get in trouble, we have to have a way of protecting the patient, the idea made sense. So this is we were setting up, and this is Min and I. This is Min here, this is me here, and this is our circuit, and here's our oxygenator. Here's the Angiovac filter, and we're basically priming. We use a priming bag. We come down, we go through the circuit, and here's our oxygenator that we use. And schematically, it's a little easier to really understand it, so I'll just go straight to that. This is basically the system that I just showed you, and we use, as I said, a priming bag. That's our typical ECMO circuit. The line comes down, goes into the Angiovac filter, which traps the clot, comes down into the centrifugal pump that's generating the negative pressure, because this is what's going to go into the patient's connected to the cannula itself, comes through. We have a collection here if we wanted to flush some blood through, so we could see what's in the cone, or flush some saline through so that we can clear it. And then what we did was we put a Y connector here and a Y connector here, and we interposed just an oxygenator, so that as the blood comes down, if I'm clamped here, it's nothing more than an Angiovac system. This would be connected to your cannula. It's sucking through, capturing any clot or unwanted material, whatever it may be, comes down to your cone, comes out, and again, this is clamped, so it's going to preferentially go this way, obviously, back into the patient in a different venous access, usually the femoral vein. So there's your closed loop. But if you get into trouble, you can clamp here, open here and here, cannulate the femoral artery, take it out of the vein, and now you have a VA ECMO system that has a bypass line in it. And this is our original version of doing this. Now, since then, we've looked at it even deeper and kind of thought, okay, well, what else can we do to make this work? So we figured that let's say you had a situation where the clot continued to be able to be retrieved, but now you've made this decision and all of a sudden you don't have the ability to do that. So we came up with this system, and here you see the blood coming out of the patient, going into the filter, coming down to the pump, bypassing the oxygenator. Clamp here, clamp there. Pretty much what I just showed you. If you move the clamp to this location and open these, you're going to go through the oxygenator. You'll have VV ECMO. Mm-hmm. So you could actually oxygenate in that way, at least partially, right, if it was not a full occlusion. Here it demonstrates that. You have the blood coming in like this, through the pump, going through the oxygenator, now oxygenated blood. It could either be VV, you could move it to the artery, whatever you want to do. But the beauty of being able to do it this way is, I could now, if the filter became completely occluded, pull this cannula back so you're not actually using it. You putting it in wherever you need to get access, to get blood, and now you're bypassing this filter entirely. So we created this second bridge. Then, if you really wanted to, you could continue to do the treatment, which you see here, where you're still going through the filter, even if you transition to VA ECMO, if they said, we really think we can get this, because if they do get it and you pull it back, you're going to relieve the obstruction and the heart is going to continue to be able to beat then normally if you can get it resuscitated with medication or possibly even some mechanical support. So this is how I like to do the Angiovac procedures. And if you're not used to Angiovac, you just have to go look it up, because the talk today is not really about Angiovac. It's really about how easily it is to integrate just an oxygenator like we do ECMO without this reservoir. Because once you add this reservoir, you're really increasing the complexity, because you have to be now concerned about air entrainment. But if you were going to do a sternotomy and do a pulmonary embolectomy with full bypass, then you're going to have to discontinue the ECMO and you're going to have to transition the patient to a full bypass circuit. So this may have the advantage of being able to do that easier, but it has, I think, more disadvantages than advantages, because you're probably not going to have to go on full bypass and do a full embolectomy. You're going to be able to do something else to get this problem resolved, because the patient's stable on mechanical circulatory support.
Yep.
Have you done these? You've done one of these cases. What do you think of them? Do you like Angiovac?
Yes. Yeah. We
Is
had
it-
2 recently.
Yeah.
That young lady that
Yeah.
did very well.
Well, it's great, because if you have a patient who has a, let's say see, my talk was very quick. You think yours was short. Mine was really fast. You have a patient that has a infected thrombus on a central line, and you can't pull it out, because if you do, it's going to go away. This is a great way to solve that, because otherwise they were getting surgery.
Yeah.
That was going to be a sternotomy.
Yep.
And this really, I think, is very helpful. And I don't know how you feel about this, but they're actually using it to clean out the left atrial appendage. So patients that have Watchman procedures, you're starting to see some outgrowth from the exclusion device, and they're actually going transseptal in the right atrium, transseptal into the area of that and cleaning that off using this. Don't know what your thoughts are on that, but it's pretty aggressive, but it'd probably be better than sternotomy.
Agree.
Good. Okay. All right. So there's that. Now, my next lecture, because we want to get to these simulations, is who died and who lived and why. And this is going to be, I think, a very, very interesting discussion. Let me get that pulled up. There it is. Okay. Presenter view. All right, there. So let's just go there. I'm just going to go through this very quick. ECMO overview, why, how, and outcomes. You have, obviously, what do we do ECMO for? And we'll keep that relatively short, right? Circulatory collapse, cardiogenic shock, MI, PE, post-cardiotomy failure. Of course, we just got through talking about PE, right? Pulmonary failure, severe ARDS, status asthmaticus, or any cause of pulmonary failure that you can come up with, where it's pure just lung, right? How do we do it? VA, VV. We can have exotic cannulations, VAV, which you're going to see today, how to do it, VVA. So where the dash is where the oxygenator goes. So VA ECMO is veno-arterial. VV ECMO, V-V is veno-venous ECMO. And the dash is where the oxygen is. So when somebody says you're on VAV, where the dash is where it goes. So you're you're going from, and actually that's incorrect. That should not be that. So I want you to ignore that one. I can't change it right now. It should be V-AV because you're never going to access the artery. So actually that one is an error. VVA means you have 2 venous access, 1 arterial return. So you would never have VA-V. It would never happen. So it should be V-AV is what it should be. You can have dual circuits, VA, venous access to arterial, venous access to arterial. You can have that. You can have VV. That's called the butterfly technique, where you have 2 venous access going to 2 different circuits and 2 different venous returns. So usually what you'll see is 2 femoral accesses, one coming into the right IJ, one coming into the left subclavian, and they call that the butterfly technique. And that's when somebody really needs a lot of flow.
Okay.
They're big, young, muscular, and they have very high basal metabolism. You can have central cannulation. You can have peripheral cannulation. And this is just an example of all those things that I just described to you. Remember, where the dash is where the oxygenator goes. Okay, and there's what it should have been. Remember I showed you that one? It's VAV. Venous access, oxygenator, arterial return, and venous return. So you would see it like in this particular case, what you're looking at is a venous access coming out of the femoral vein, going through the pump, the oxygenator, one going back to the femoral artery, one going to the right IJ. And that's what a V-AV would be reflective of. This parallel VV circuit you see here, this is the butterfly technique that we talked about. So outcomes, generally speaking, with VA ECMO, they quote about a, 40% survival when you look at all patients for any reason at all. You lump them all together, and when you're doing a consult on someone, they generally will say your likely chance of survival is about 40%. This is survival, not mortality. So your risk of mortality in this case is 60, or your chances of survival are 40. With VV ECMO, it is 60%. So that's sort of what you would, as a baseline for whatever reason you're putting somebody on ECMO, and you're just asked, can you give me the statistics of what's their chance of survival? 60% is generally understood to be what it should be. But this is where this gets real muddy, real concerning, and very frustrating for me. I think I sent you this article, if I remember. And 1-year outcomes with VV ECMO support for severe COVID-19, not mild COVID-19, severe COVID-19, written by Smith and colleagues out of New York. And they took 30 patients, so it's a very low end number, very small sample, right? But nevertheless, 30 patients in 1 year, I mean, that's for what we saw more than that, but depending on how long they're on, not necessarily a lot more than that, Yeah. Between the 3 facilities, we did about 110 total patients, but the number of ECMO days we had was extraordinary because we had them on for so long and so many. So 6 maybe going, 5 going, 4 going, but for like 2-3 months at a time. So it was very, very difficult. But anyway, some information that I thought was very interesting, very elucidating to me is their BMIs were 30. So range was 25 to 35. Although when you look at the actual data, morbid obesity should not be a direct excluder or a exclusionary comorbidity, direct excluder of putting the patient on ECMO. There is a report of a guy who had a BMI of 79, was 19 years old, who actually survived a multi-month ECMO run and went home. Now, what's his quality of life is a totally different question, but there's been any number of reports of patients with BMIs of 40 and 45 who have survived ECMO, and again, survived ECMO to decannulation and going on to having a reasonable quality of life are two different things, and we really have to, I think, differentiate those things, but they don't generally do that in the studies and these articles that we read, so you have to really do a lot of investigating. But days from intubation to ECMO cannulation was 1 to 4 days, and if you recall, during the height of all of the COVID, we were putting patients on ECMO before intubating because intubating them was considered to be the worst thing that we can do. I'm not 100% convinced that was right. I'm not sure. I don't know what I really think about it all.
Very definite small group of appropriate patients for that. Mentally, physically, you have to look at all of that before deciding, is that an appropriate patient for awake ECMO? Because once their air hunger kicks in, it just becomes impossible, which we saw with a couple of them that we tried to put on awake. And
it was pretty barbaric. And, you know, it was, I mean, but that one guy made it. Remember that guy that was the employee of, he was an employee of the hospital. He's back to work, right? But I remember when we did him, he wasn't liking it.
no,
You know, he was not liking it at all.
right.
And I was surprised that I was surprised that I was surprised a lot of them that did make it made it. But I think, well, let me talk about our move on from here. Another thing that I think you have to take note of is the PaO2, the PF ratio, which had a mean of 80, 61 to 87 was the range. They used the cytokine hemoadsorption filter 33% of the time, so 10 out of the 30 patients. I really wish we had that device here and used it on occasion. I do think that it has good utility. It's a whole blood, so it's not a plasma molecular adsorption filter where you have to run the blood through a plasma separator, blood plasma separator, so big hemoconcentrator that allows the plasma to cross over, and then run the plasma through a adsorption filter and then reconstitute plasma and cells back together again, back into the patient. This does it with whole blood. So the CytoSorb, I think, has an advantage in that way, and it has shown to be pretty effective. But anyway, survived VV ECMO, 93%, 28 of the 30. Survived to discharge home, 27 of the 30, or 90%. Duration of VV ECMO was 19 days, 11 to 45 was the range, but average, the mean was 19 days. Much shorter than ours. Much shorter than ours. And then supplemental oxygen. I really don't want to discuss that. Let me just go with the ones that I highlighted. Survival at 1 year after cannulation, and really that should be, I guess, after decannulation. 1 year survival was 26 of the 30 patients, 86.7%. That's a remarkable number. Remarkable number. Now, I I have been struggling. In fact, I need to get with you because I need to get through some charts. Um, but I have a preliminary. I don't have it written or a slide. I can just articulate it. We can just discuss it. Preliminary data on our outcomes, and it's nowhere near this. It's in fact it's so far away from this. It gives me pause, but don't want to exaggerate that just yet. Now, if you go and look at this article, which was designed originally as an article to measure whether or evaluate whether cerebral oxygen saturation, measuring the NIRS, the cerebral oximeter, when you're moving a patient on ECMO from hospital A to hospital B, had benefit. But in the process of that, they published the data with survival information, notwithstanding there was never a reason why the cerebral oximeter prevented or not having it resulted in death. But they were just pointing out the feasibility of this, and that's important to understand. But in their cohort of 16 patients, so roughly half of the N of the other, but I still believe it's suggestive, 8 of the 16 patients died. And this is also for COVID-19, okay? So it's written SIO 2022. The other article was 2022. These are all COVID patients. So they had a 50% survival or a 50% mortality. Again, very significantly, and this is only to decannulation, not 1 year survival, but very different experience from what the previous group had. Why? Okay, I don't know the answer why, but it's really something we have to look at. And then when you go even farther into this data, and so we could just you'll notice that we're just going to keep building upon this. This is a validation study of RESP. So we all familiar with the RESP score. We have it on our app, by the way. There's been some people who have validated RESP and said it's great, it's very predictive, very accurate. We've had other people who have evaluated, tried to validate RESP and said that it's kind of, maybe it's okay, maybe it's not. It really depends on whose article you read, and it depends on how they decided to try and validate RESP. Again, I don't think there is any hard and fast way of saying, but I think these scores are very good to see if you are falling far outside of the range, and I think that can tell you several things. It can tell you that you are selecting the wrong patients, over selecting patients that may not actually need it, or we're not doing it right. It could be all of those things, right? Or it could be a combination. So anyway, in this particular study, their N number was 1,985, a tad bit more robust. They had overall 1,051 survive, 934 die. So it was pretty doggone close to a 50-50 split. So about what we saw with that original study I showed you, not, and this is multi-center, not looking at only that group that had these remarkable outcomes. But you'll notice some very significant differences. Hours on mechanical ventilation prior to ECMO, 89 was the mean. Oh, I just shut my computer down, didn't mean to. 80, it just did it automatically, I think. 83 were the ones that survived. 98 were those that died. It's not statistically significant, but it is suggestive, certainly, that it may be Well, actually, it is barely statistically significant, right? 0.05 would be so 0.046 would be, yes, so it's just barely. But it is certainly strongly suggestive that the longer time of mechanical ventilation prior to ECMO may have an impact on your survival. You'll notice the PF ratio mean was 70, 72 on the survivor, 68 on the non-survivors, so much lower. The previous one where they had those very great outcomes had PF ratios of 80 was their mean. Their peak inspiratory pressures were pretty high, 33, 33.5, and 35. We saw much higher than that. But the range was 30 to 39, 30 to 38. But these were pretty consistent. Not much of a difference in the actual number. But again, higher did barely statistically significantly result in a better or worse outcome. AKI was seen 207 of the 1,900, or 20% versus 24% in the non-survivors. That's probably expected. Obesity, you had obesity. It was considered a BMI above 30, and 61% total. 62 of the survivors, 62.8%. Versus 60.7. So you can see obesity is not an independent indicator of mortality. You really have to look at more than just one thing. Now, that doesn't mean extremes, but I get fairly, concerned when I see putting somebody with a BMI of 42 on ECMO. Our experience has not been very positive with those patients. And I don't want to, I really want to stay focused on this, but it's an important it's an important concept that I have to bring out. Once we put a patient on ECMO, and then a second patient on ECMO, and then a fifth patient on ECMO, and we're now going to the somebody's decommissioned machines because they got no machines that are sitting in a warehouse in order to be able to add that sixth one, or taking a heart-lung machine and adding that sixth one. We're committed. And so if we poorly selected, because that was the patient in front of us, we don't have the resources for the other patient who may be a much, much better candidate. And that, of course, that needs something, other procedure done. So, I think that's an important thing that we have to really consider. So when you look at obesity, the overall patient, poor hygiene, not taking care of themselves, BMI is 40, 42, 45, even though statistically that should not be an independent exclusionary comorbidity, in my view and experience, I think it should be.
Especially when you're talking about COVID patients, because, early on when you put them on, I feel like proning goes hand in hand. And, the ability to manually prone a very large patient.
Oh, very hard to do.
Very hard to do.
We've done it, but very hard to do. And you can't put them on the prone.
And your risk
can't put them
for,
on the rotoprone.
Yeah, you can't put them on the rotoprone, which means you're only manually proning. So how big of a bed are they on? How many people is it physically taking? What's your risk of decannulation when you're reaching across an area this big?
And then secondary infections.
And then, again, compliance-wise, can you really get that diaphragm down and out of the way and let them have some lung rest?
Lung compliance, right. So
and
you have all this
good
pressure.
recruitment and all of that. When you're fighting against that, it's just, that's why BMI is such a big thing with me, because I'm just thinking, what's our ability to do everything that we need to do for the patients with the smaller BMI that we can do? How is that going to affect our ability to come off?
Yes, agreed. Well, it's going to affect it very, very, very much. I totally agree. And I want to talk about that a little more, but very quickly, because I have my last slide here. So basically what this article ultimately did, and I'll just show you here, is that it really did a good job validating RESP. So this is one of those articles that really was able to validate RESP with those 1,985 patients that they looked at and compared it to the RESP score. And what they found is written down here. A RESP score of 0 coincided with about a 50-50 probability death survival. So on the x-axis, you see probability, that's probability of survival. On the y-axis, you have your RESP score. Here's 0, come up, look at it, it's plus or it's just maybe a little less than 50, but that's it. A RESP score of 0 gives you about a 50-50 proposition. And so they concluded that this is a score that has a lot of validity to them for VV ECMO and respiratory COVID patients in particular. So the lower your RESP score, the more negative, lower your probability of survival. So that's how it works. So if you have a RESP score of 5, then you're at a 60% survival and so forth. But if you have a RESP score of 5, should you be putting that patient on ECMO? And that's yet another question. And I would love to know what the RESP score was on those patients from New York that they did. I wish I had I don't have the data in which to calculate it, but it would be very interesting to know if the RESP score was 0, -5, +5, 7. What was it? Because again, that wasn't the point of their study. Their study was more, I think, sharing of experience, anecdotal, just because of the end number, that would make sense. But I have a hard time believing that. But with that said, getting back, I'm done with the slides. Thank you. And obesity is a funny thing because they can be big people, all over big people, like Billy. Billy was a big man. He was obese, but he was a big man. But the ones that have the big belly, their weight is all here. And if and I see this happen all the time. And, and Vicki asked me, why do you always talk about ECMO? You talk about ECMO too much. Again, we could talk about it forever. But you can't lay those patients flat because that belly pushes the diaphragm up. You're taking already compromised lungs, reducing the the thoracic space. You're basically compressing everything. You take this big, giant, huge bellied person, and you see these little itty bitty lungs, and now you're just shoving them all back, and increasing the intrathoracic pressure. So you really have to, you really can't just sit that patient up. You really have to reverse that patient, reverse Trendelenburg, to drop that weight down and pull the diaphragm back down. It really helps you a tremendous amount with your peak pressures on the ventilator.
Absolutely.
At least that's what I've experienced.
Absolutely.
But you just don't see it a lot. They leave them laying flat, thinking that that's the place they need to be. And then cannulation technique. I really like this that Crescent catheter that we put in this latest patient. It has made mobility for him really, really nice. But you do have the risk of now venous insufficiency on the left arm, possibly even the left part of your head. So it's not without its limitations versus the right IJ technique, but having it in the right IJ or using the Avalon, which can only go in here, you have those lines coming over their head and flopping on their neck and pressing on their ear.
Position issues and
migration. There's so many other issues, that are a problem. Okay, let me log back in case I had any questions. I apologize for that. And we can get I think the next thing is the simulator. So how are we doing on time? We're doing great. Do you have any thoughts? You can kind of take over while I do this.
No, I am very curious about what those scores were on those patients, especially with 11-day runs.
Yeah, me too.
Yeah.
Me too. I think it's I would
11-day run for COVID is pretty short.
Yes. Now they had 45 days, their range, right? But how many? You know, but that was their. You have to look at their median. Their median was 11 days.
Yeah.
So you know, I mean, how many were 4 days? And what did they go on ECMO for?
Exactly.
Yeah, but
I mean, when you're talking about COVID versus, you know, okay, submassive PE or massive PE, very different.
yeah, or status asthmaticus.
Yeah.
You know, you can resolve that pretty quickly.
Yeah.
I mean, those are great cases. Peanut allergy.
Yeah.
Somebody that goes into, you know, severe
Anaphylaxis, yeah.
bronchospasm
Yeah.
because of a peanut allergy. You put them on ECMO, they're only on ECMO for about 24 hours and they're done.
Yeah.
And they're great. Okay, they just recover. But, you know, but the problem is this. People read those studies and go, look, we can do this. And that's where I think this whole thing has become very muddy, very like confusing and stuff. And I'm very supportive of using ECMO. I just want it used appropriately. Right. And I don't want people to believe that are maybe working in, you know, I don't know, I really don't know Muncie, Indiana very well, but, you know, somewhere like that, that doesn't have a big, you know, it's not a big medical center. It's a 100 heart a year hospital, mostly have a heart program for a cath lab, 1 or 2 perfusionists. You can't do this. You just cannot, you know, and not unless you can put it in, they're going to be out that same day.
Yeah, you can't sustain it. Those 1 or 2 perfusionists have to sleep. They have to take a day off. They have to do pump
there's
cases.
no days off.
They have to.
There's no days off. No, but it's inevitable. You'll put a patient on ECMO, and then you have to have an ECMO, right? And if you don't use it, you know, you lose competency. So you need to have practice. So now you need to sort of invest in all of that. But one of them is on vacation. You have 2 perfusionists. The other one gets the ECMO, and they're there just stuck. And then
Now they're sleep deprived and they've gotten COVID
well, no worse.
and they're out.
A STEMI rolls through the door, and they go and they're going to stent it, and they perf the coronary, and now the patient is unstable in coding. Well, now what do you do?
Going to the OR.
Well, how?
Yeah.
There's no one to go.
Yep.
How? How are you going to do that? Who's going to do it? You leave the ECMO patient?
Where's your ECMO nurse specialist?
Exactly. And that's what this simulation is all about.
Oh, no.
You're the ECMO specialist today.
No.
All right. So if I'm going to pull up what we're going to use for slides for this, David, and just so you can have it as a baseline, we'll take a short break, and I'll get everything over there ready to go. We've already got the ECMO turning, but I'll get all the simulators going, and then we can set the screen up, and we'll go from there. So it's going to be this one. There. Okay. Okay, there you go. Okay, cool. Yeah, I have to go over there and get all the monitors ready to go. I mean, I have to, if you don't mind. Yeah, I just need a couple of minutes, 5 minutes. Oh, here we go. Here. Okay. Hello, everyone. Hello. my pointer.
Oh, boy.
Okay. So what I want to do, which camera are we using? That one? That one there, too? That doesn't matter. I'll go to that one. No, you can't see me now. You're just looking at my feet. That didn't look good, David. Didn't look good. Yeah. Okay. Well, I want to just go through the entire thing, right? Is what I want to do. But I don't want people to just see feet walking around. If you can help that, I don't know what you can do, but I want to walk around a little bit and look at something. Maybe would it be better if Darcy held on to that camera? Yeah, do that. Let's do that. That makes more sense. So we can move, and we don't feel like we're being discriminated against. There you go. There. Okay. There. So you may want to. There you go. Yeah, that works perfect. Okay, so now you can come over here, Kimberly. So we're going to move up here. Okay. So. Well, yeah, so just show us too, okay? So we're a team, all right? You can show yourself too. Turn it around. There's Darcy. Hey, Darcy. Very good. Okay. So this is SimMan. So this is our mannequin. Okay. In this particular case, we have the patient cannulated femoral venous, femoral arterial, and the all of the connections for this are inside the belly. So we have all of our lines. We have chest tubes in the patient now as well, and I'll go over that. The patient we have all the ability to cannulate both sides. We have in fact, you're going to see that later on today. We have the ability to cannulate in the neck. We have the ability to cannulate the subclavian. We have the ability to cannulate all this stuff. Patient is intubated. Patient has a Foley catheter in. You can see it here. This patient, we'll talk about this particular scenario, was given methylene blue. We have chest tubes. You can see that this patient is bleeding. We'll talk to you more about that and on this particular scenario. And then you have the line coming this way, going into the centrifugal cone of our ECMO, out the cone, going into the oxygenator, coming out of the oxygenator through the flow probe now as arterialized blood and back into the patient. And we can create whatever circuit we want. All of our controls are here, but David, go ahead and show the setup. So we'll look like this as we're doing the scenarios. So we'll be able to show you everything that we're doing, and you'll see the physiologic monitor, you'll see the ventilator, you'll see the flow here, you'll see the pressures down below, the ECMO inline, which would be connected here. It's not actually physically connected, but it is connected. And then you would, and that's what we're going to be able to do. And then I'll show you the simulator box. The lines come out of the patient and end up going down here. And this is the Eigenflow ECMO simulator, which you see there. And all the lines go back to a reservoir, which is underneath this cap. And I'm going to go back there and move it just so you can see what it looks like. And here it is here. And basically what I've done is I've taken basically a typical venous reservoir, and I have a way of bypassing it if I want to, or going through it and back to the simulator there. And the fluid that I'm using for this is a glycerin solution so that it changes the viscosity, and we're able to use the transonic monitor and actually measure recirculation or oxygenator blood volume. Now, over here, what you see is the ECMO control, the ECMO simulator, the Eigenflow has an iPod to it. I don't know if you can see that or not. Kind of move it up a little closer. There you go. And it has various scenarios that you can choose. Leaky stopcock, ECMO pump chatter, kink tubing, hypovolemia, cardiogenic shock, tamponade, and differential hypoxemia. Maybe we could do it like that. It doesn't come out too well, the color, but yeah, that's good. But it all runs off of this iPad, and you can run various scenarios with it, which is very helpful. And then over here, what you see are these 4 iPads, This is the instructor monitor. I don't know why it did that, but it did. But that's okay. Yeah, there you go. It's working now. This is the instructor monitor for the patient monitor that you see here. This is the instructor for the ventilator that you see here. And David, you can show them all of that, what it looks like on the screen. You only see, obviously, the student monitors and the instructor monitors on the ECMO we run over here. So let me get this to run again. There we go. And just give me a second and we'll get this first scenario set up. So if you have an interest in wanting to do an ECMO simulator, I highly suggest you contact Curtis, Paul Curtis at Curtis, here, where am I? There, at Curtis Life Resources. And he can help you set you up with a very nice ECMO simulator that I think works really well. So, and please tell him I sent you, which would be very helpful to me, okay? Because I do want to, but I'm so far very impressed with it. Y'all get to see it operate today, okay? All right, let me make sure I get all of this set up. And we'll get this patient coming back from the ICU. All right, update. Okay, that looks bad. You think that looks bad enough yet?
Yeah.
This looks good? This looks good. Okay. All right, so let's go ahead and throw the slides up, David. And you can put that back, but thank you. Oh, I have to mirror it again? Okay. Why does there always have to be technological issues? Okay. Perfect. Okay, so here, why don't you come stand over here?
Oh boy.
There, that's a better spot because you're out of the frame. So what we have here is a 62, and I guess we're using that camera. So can we go to camera 3? It's kind of uncomfortable for me to be doing this and this. Or camera 1, I don't care. Well, that looks terrible. You stay right there. Don't move. You don't move. Take that here. Why don't you move to take that away for a second so we don't have to see it. Okay, there. When you say push it down, you mean like this? There. How's that? There. I think that works pretty well. And I can pull it out a little bit more. There. All right, that looks good. I like that. Yeah. And we're kind of in focus. We look good. Yeah, we look good. Okay, that's much better. I like that better. Okay. So we have a 62-year-old patient. He looks young. Mm-hmm. He looks younger than that. Mm-hmm. 162, it's a female. So don't, come on. He identifies as female.
Eyelashes, red hair.
Yes. 162 centimeters, 79 kilograms, 1.84 BSA. The patient is a cabbage ×3 with mitral valve repair. They put a rig in. There was residual mild to moderate MR, typical. Mm-hmm. Pump time was 160 minutes. Clamp time was 89 minutes. They used Delnito cardioplasia. In the operating room, they gave 4 PRBC, 4 FFP, platelets, 10 of cryo. Levo is at 16. Primacore's been on. And the patient was given methylene blue for refractory vasodilatation or hypotension, and we have made it to the ICU. So the next slide. We were failure to wean, VA ECMO, 22 French right femoral vein for drainage, 18 French right femoral artery for return. Flow rate is 3.5 liters per minute. Blood pressure has a very low pulse pressure. Pulse pressure is about 5. The PA pressure is pretty high, 52 over 32. And the pulse ox is reading 100%. It's over here on the left figure. I don't know if you can show that on the Mevo camera. Can you switch this to the Mevo? Well, we'll do that in a minute. ABGs show a persistent lactic acidosis. This right here is what I'm looking at. Can you see? That's okay. We'll do that later, okay? And what we're starting to experience is line chatter. And Darcy, I think I am going to need you to help, if you could. So, and I also want to show you that go ahead and take the camera off and use the camera here. And just let your dad switch to that camera. Mm-hmm. Just this monitor, just the camera 3 to the Mevo. There, and just show right here this finger. If you can zoom in a little bit, very good. There's our pulse ox. We can see that the patient's been bleeding. There's 1,700 in the left chest tube, and there's 800 in the right chest tube, and 800 in the left chest tube, and we're in the ICU now. We're flowing. You can see our pulse saturation, and I'm going to start this next process of this. Okay. And we're going to see how this plays itself out. Okay. So, what I want you to focus on is the venous line, which is here. And I want you to watch the flow, which you're seeing here on the monitor, and the pressures. But just keep an eye on all of these things, especially this line right here. You see the flow starting to fluctuate a little bit.
Do I have to adjust at the console?
Well, this is what you would be seeing in the ICU. Well, now, it's not doing it as dramatically as I would expect it to, so give me just a second. And it could be that I just set it up wrong, and I think that's something that I do sometimes. But I want to start the pump chatter process. Okay.
You have a little.
There you go. Now, take a look at the flow again. You should be seeing the flow will start. Give it just a minute, and you should start to see it begin to vacillate. Oh, I know the reason why. Here, you can pull that back. You can pull that back. I know the reason. It's technical difficulties of Joe. I have to clamp here first. Okay, now let's watch it. So when this starts to happen, the nurse in the ICU, look at our flows. You're seeing it go down, and you can see it starting to move. You see it moving right there, just a little bit? You see it? Now, that's not too bad. What you will frequently see, and go ahead and keep that line right there. What you will frequently see, and it's just not that dramatic with this, is you will see that. When that happens, you see our flows changing constantly, and what generally will happen after that is you will start going into a crisis. So now we have flows that are constantly changing. You see it fluctuating. You see our pressures vacillating like that. And this is what you would expect to see if you had a hypovolemic problem. So why don't we go ahead and you and I could discuss that. What would you, as a clinician, and of course this is going to happen too, when you have to make, we now have to make some decisions. What are we going to do? Next course of action.
Assess your patient.
Okay.
So obviously we have a bleeding patient. So we're going to need to give some product. So if we don't have blood in the room, you can start out with some albumin. You can turn your RPMs down until you get your volume resuscitated. And I would be ordering blood product as well as sending coags because, again, probably you have to figure out, is it a coagulopathy or a protein deficiency?
Right, but our problem is, from an ECMO perspective, we have an immediate problem.
Yep.
I've turned the flow up to try to make it better, but it isn't going to get better. All we do is keep seeing the flow vacillating because we have an inflow occlusion. So focusing only on that, one of the things you would want to know is, what are the labs?
Yeah.
You want to know what the hemoglobin is.
Yeah.
So we can come over here. We can ask for a hemoglobin. And it will give it to us. The hemoglobin is 19, or the hematocrit. The hematocrit is 19. So what do we want to do? 500 of albumin? Do we want it to get the flow up, or do we want to get packed cells?
We want to get packed cells.
But if we wait for the packed cells, we're going to continue to have severe hypotension, severe hypoxemia, and a real problem. Mm-hmm. So we have to make that decision. So what I would do, we're getting the packed cells, order them, get them as fast as you can. I'm going to give 500 of albumin, maybe even a liter of albumin, knowing full well I'm going to dilute the patient even more, but I have to do something because I have a hypovolemia.
You can't maintain,
It's a post-op heart. They're bleeding. I'm not going to put them in I'm not going to fill them up too much because they're going to keep bleeding while the packed cells are coming.
Correct.
And then we can, of course, deal with all the other things. So we will go ahead and get all of that stuff in. So we gave 500 of albumin. And we're going to the albumin has gone in.
Don't slow down on that person going to get the blood. It's just a
And
Band-Aid right
they
now.
have to go faster. But this at least gets us back to what looks like a reasonable blood pressure, a tolerable blood pressure, and we are looking a little bit better. So and our flow seems to be stabilizing. It's better than it was. We're back up to just a little bit of chatter still. But one of the other things that you can do to help mitigate some of that chatter is to turn the RPMs down. Sometimes you get actually a better flow, a better amount of flow if you do that versus allowing it to continue to do the chatter. Okay. Good. Okay. That should have taken care of that, and we should be right back to normal. And now the volume is in, the blood is in, we're getting all of that going, and the situation has resolved. So when you have this presentation, and show that line again, because I'm going to do it this way. So show the line right there. And Kimberly, here, you point to where I wanted to look at. And
Okay.
watch the line. You will see it. See that? That's mild. But it can do it just like this. And I've seen it do it many times. Where you actually see it jumping like that. That is classic occlusion of the venous line. So there you go. That takes care of that problem. All right, good. All right, and that concludes that particular scenario. So we did the line chatter. Now, the other thing we're starting to see, and we're good with that now. Thank you. And you can go back to camera 3. I feel like a director. Camera 3, cut to 2, cut to 4. It's really fun. Okay, so now let me do this. And you can play if you'd like. You know what you can do? So we have air in the cone. We can get air in the cone for a variety of reasons. One of them is having too much resistance in the line and it'll cavitate. So I usually turn the flow off, let the air kind of dribble up, and then I just turn it back on and pump the air through. It goes right through the simulator. It doesn't hurt the patient at all. It's amazing. Okay, the next problem we're having, and we're going to do some blood gases here, and usually I have these already done, but I don't have them done today yet, so just be a little patient with me, but I'm going to do this. I think it's going to be very interesting, something that we see fairly common.
Where's your sweep dial?
Okay, that's good. Okay, so let's take a look at these gases. So we've got a, can you read them? Here, I'll read them off to you. I know, our glasses. Can you make that big, those gases? The
It's not-
top left corner.
No, that's the blood gas in on there. That's the CBC
Oh.
and the coags. It still had the CBC one displayed.
Why is it doing that, I wonder? Huh. There's my ABG. Oh, I know what to do. Oh, I see. No, no, that's. I love technology. It doesn't make any sense at all, but.
There we go.
There. I had to put it on hide in order to make it come up. Isn't that crazy? It was inverse of what you would expect it to be. Okay, so can you make it big, the top left corner? There you go.
Oh.
So our pH, is that better?
Yes, I can see
pH
now.
is 7.26. We're on ECMO. Remember that now. PCO2 is 41.8. PO2 is 180. So that's good. We're getting good. We've got a good effective ECMO. Base excess is -7. Bicarb is 19. SaO2 is 97. FiO2 on the ECMO is 100%, and the vent's 100% right now too. Lactate is 4.8. So, what's the problem?
We're still a little behind.
Good thought, but that's not the answer. There's another answer. We're VA ECMO. Came out of the operating room. We used a 18 French femoral arterial, and this is a woman.
Okay.
So what could be the problem besides we're behind? We have a persistent lactic acidosis. So on physical exam, what would we be looking for?
Limb ischemia.
Limb ischemia, and we happen to be looking at the right foot, and we notice that it is dusky, there is no pulse, and it is cold. What do we need to do?
Perfusion sheath. Start with that.
We need a distal perfusion catheter. The question is, and I'm going to need you, Darcy, how do we do that when you're already in the ICU? You have the access for it, but you have to be able to do it, and we're going to do that right now.
Okay.
So what I'm going to do is come over here. We would be obviously putting on a pair of sterile gloves. This is for you. And so I need you to take the camera, and I need you to focus on this area right here, David. You need to zoom in on this. Okay. And can you show it, maybe bring this just like this? So we want to show, so here is our return. It's red, okay, and you can see it's the red line. It has the red mark on it, okay. Coming in, and here's a lower lock on the connector that's feeding our femoral arterial cannula here. What we need to do is they need to stick the SFA, which we can't do in this hard patient, but we're going to simulate that. And then we're going to connect it to this and show you how we go about doing that. So this is what we want to see, Darcy, is right here. So you're going to need some help. You're going to take a couple of people to do it. And we're going to have to
Let me remove my hands there.
take the patient off of ECMO momentarily, correct?
So to dial down there.
No, I'll just clamp it. So you can turn the RPMs off if you want. You don't have to, though. So when now we would be sterile. Obviously, we would clean the area. We'd be using sterile gloves and
We've already
all of
got
that
the
kind of
sheath in.
thing. The sheath is in, and it's gone into the patient like this. Now, it may be you would have this stopcock turned off this way so that we know we're not going to blow
Bleed.
everything out or whatever, and we would have de-aired that section, and now we're just waiting for this section. So probably turn it this way because this is stopcocked off. We don't want to bleed. Very important to remember to use a non-vented cap. It's non-vented. If this was a vented cap, you
Trickle,
turn the
trickle, trickle.
stopcock, the patient will bleed out through that, or the pump would bleed out through that very rapidly if you had it like this. So you have to remember your stopcock discipline. So I'll take this here, and when you're ready, let me know when.
Clamp.
Okay,
Clamped.
that gets inserted. We turn this on,
Now we're open
And
to
now-
there.
uh-huh.
Unclamp.
and you would, I'm going to do that just for now.
Okay.
And of course, you heard the alarm, but it was very momentary, and the patient really is not going to endure a tremendous hemodynamic instability. It will be momentary, but that's a pretty quick way of solving this problem. What's very important is to remember you need to have a ability, because if this was a non-lower lock stopcock connector, you would have to cut the connector in, and that's going to take a lot more time to do than being able to do it this way. But having stopcocks and having lower locks carries its own risk of coming apart and bleeding. We're going to be talking a little bit more about that. But you do need good two competent clamps in order to be able to do this, but it can be done very quickly. Okay, very good. Let me see what the next, so we talked about the possible problems, which was, now, it could have very well been, and that now, of course, the foot is pink, it looks better, it's warming up. but you're still going to have to wash out that acid, and it's going to take you a little time to do that. You may have to give an amp-bicarb because that was a pretty low pH.
Yeah.
And keep that in mind. The other thing I think is very important, a very good point to talk to people about is, if this patient were already on CRRT, it can, because it clears lactate so well, mask a problem. And that a physical assessment of the patient, especially VA ECMO, is critically important for that distal limb ischemia. That is not an uncommon problem to have.
Yep.
They're on levo, they're on VA ECMO, they got a big cannula, probably have, and it's a small cannula, but it's a small vessel, and it can be occluded very easily.
Yep.
Agreed? Okay, very good. Thank you so much. Okay, you can set that back up. All right, so let's, we've corrected all of that. Let's see what we're going to do next. Okay, so this takes me just a minute to set up, David. So go to cut our mics so I can set this up, and we'll do our next scenario. And we're going to go to full screen slides so you can do that. Okay. Go ahead. Mics are back on. Okay, good. So let's go back to, can you go to camera 3? There. Okay, so now we're going to go and continue our scenario. You can see that our ECMO flow has still stayed stable. Our numbers still are looking pretty good. But this is something that's really interesting. Your second day post-op, and go to full screen on the slides if you could. What you notice is your pulse ox reading is higher than the blood gas, and we're going to show the blood gas here in a second. But your pulse ox, so go ahead and go back to this monitor, to this here, is on the left hand. So I'll just put this right here. This is just imperfect. It's an imperfect system. Here, can you go to Mevo? There you go. Is on the left hand, okay, as you see here. All right, that's good. Thank you. And so you have that, which is reading 92. So that's a change. Now, what's going on? Well, let's look at the ventilator. If we notice the other day, the ventilator pressures were much lower. We're seeing the ventilatory pressures getting a little higher, peak pressures of 23. Still decent tidal volumes, but even the tidal volumes are down a little bit. Certainly we could go up on the vent, which even if we did, I think we're at 70% right now. We could turn it up to 100% and see if we see any change. So we don't want to leave somebody on 100%, right, for long periods of time. At least you shouldn't have to. But let's see if there's any change associated with that, and I don't believe there will be. But here's where it's really going to be confounding. If I check the blood gas, oh, I'm sorry, wrong one. Yes. So go ahead and turn the, go to the full screen of the blood gas. Yeah, the one on the top left corner. So our pulse ox was reading 91, top left corner. And now our pH on blood gas coming from the right radial is 7.40, 48.7. PO2 is only 65.8. Not too much of a lactic acid or an acidosis at this point, but saturation is only reading 87%. Lactate's 1.3. Okay, you can go off of that. So what do you think may be the problem here?
Could be, you said right radial?
Yes.
So
So our left radial is reading a saturation of 91%. The, let me go ahead and close that out. 90%, and the right radial is, that's on the left finger, and is reading 87, 92 versus 87%. The other thing we notice is there's a significantly improved pulse pressure. Now, I can handle this in one of two ways from a perfusionist perspective, but first let's find the diagnosis.
So Harlequin syndrome.
Harlequin
versus-
syndrome. You hit it right on the head.
Yep.
What we have here is classic differential hypoxemia. We're cannulated in the groin. And go ahead to the Mevo. You don't have to come, Darcy. He just has to turn it on. We're cannulated in the femoral artery. The heart is now beating more effectively. And the pulse ox is on the left side, which is closer to this femoral artery than the right radial, where the arterial line was drawn from, that has an even lower saturation than what is on the left side. But the left side is even seeing lower than it was just a few days ago. So now go back to the patient monitor, and you can make the patient monitor full screen, because what you're seeing on the patient monitor is a much improved pulse pressure. The other day, it was only 8 to 10 millimeters of mercury. Now it's 30 millimeters of mercury. So much improved. But go to the, go ahead and make that small and go to the ventilator. But we're seeing the ventilatory pressures have significantly changed. Their peak pressure is 23, and the tidal volumes were 630, but they're a little lower, which is giving me the sense that this patient may be going into ARDS. So we're at 100% on the vent, and it has not helped us. And that is a classic sign that your blood is not getting oxygenated as it's going through the lungs. And there's only two ways to solve this problem. The first way, you could go ahead and take that down. The first way is to increase the flow. But you can't increase the flow in this particular patient because they had very small vessels. You have a small arterial line. We've already seen the experience of having the cavitation that we were having with the hypovolemia, so they're going to be very sensitive to that. You're going to be limited, but mostly by the size of your arterial cannula. There's only so much you can flow, so much resistance the pump can pump against without creating its own set of problems. The second thing we can do is consider adding a line to the right IJ and going on VAV ECMO, V-AV ECMO. So we're going to actually do that.
Okay.
Okay, so what we're going to do is, if we could, I don't want everybody to see me make the connections in the belly and all that kind of stuff. So can we just go on an overlay while I put this, sort of get it ready, and then I'm going to show everyone online how we would add this additional line when you're already on ECMO at the time. Can we do that? Yeah, just like cut the mics, or just leave it up and just cut the mics, I guess, and we could just, or just whatever you would normally do. Okay, I'll cut the mics. That'll be good. Okay, so. Okay, so welcome back, everyone. So I'm going to ask David if you would, so here's our cannulation, and if you, here, let me get a bigger piece of tape. Kind of put it right there. Across his face. There, that'll work. Hold it in place. Okay, good. So now we have added a cannula in the right IJ that you see here. Oh yeah, I like that. That's perfect. Beautiful. That's perfect. In fact, you can keep it there. So what we have to do is we have to take our return, because that's what we're doing, is V access, A femoral artery, splitting it V going to the right IJ. And how would we go about doing that? Well, we're going to have to be in this section. Now, the way this generally is done is we would be draping this, cleaning this line, using sterile technique. All of those kinds of things are very important, but obviously for the sake of time and what we're doing here, we can't do that right now. So you would normally, you would do this a little more quickly, but go ahead and clamp this line on the left side of my finger.
Remarkably Calm Joe.
Remarkably Calm Joe, there you go. And then we will take these.
Oh.
That's okay. Here. Helps if you use better clamps. There you go. Now we're going to take these off. And you would be using a scissors. You wouldn't have the convenience of a connector here, obviously. Can you show this right here? Yeah, right here. So you see this right here. We would be clamping and cutting. And now we need our Y connector, which is there. And you need to think about this before you do it, because what you want is you want to make sure that you follow what is the natural flow and not go backwards with the connector. So this is going to go, oh, we could take that off. We're going to need that. Mm-hmm. So this would go in this configuration that you see here. Okay? So that way, this is flowing a natural direction. And now, of course, take this, go ahead and take this piece off. Don't need this.
I was just going to connect that.
Yeah. Oh, you had one. I'm sorry. Yeah, so go ahead and put that there. Our patient seems to be holding stable.
Ready to decannulate.
And then we add this line. I got this, you got the cannula.
Uh-huh.
And what we're going to have to do, let me fill it first. So what we would do is we would hold it up. Mm-hmm. And we would slowly fill it, and we want to get all the air out because we don't want to fill the patient full of air, and you can see how I'm doing that. It actually works pretty well. Okay. Continue to bring it down. Oh. And you always want to make sure you hold it so that, because remember, air rises. There you go. And we can make our connection. There you go. And then we can turn this on and turn this on. And we should be on. Sorry to get in your guts, buddy. It's not flowing. What did I do wrong? Hold on. Oh, it's kinked. There you go. Is it running?
Yes.
There you go. Sorry about that, everybody. Okay. Flip that back over. Now we are on VAV ECMO. So go back out of so here's our Y connector that we just connected. You see it's going this way and this way. Now the problem is, go back to the other screen. You know, the multi-panel. There you go. And you can see that now I am going to be able to flow significantly higher than I did before. But the question is, how much is going where. So I'm going to pause this just for a second. I'm going to pause all of these because none of this is going to make any sense until we have it set up. We'll just leave it sitting like that. We have increased flow. Actually, I could even go higher than that, I'll bet you. There. Can you reach it? There it goes. We'll go to 4.2. The question is, actually, it's even going to go better than that, or should go better than that. Now we have really good flow, and probably a little too high. So we should turn that down just a little bit. But much easier to flow now than we were before, because we have this 22 French in the right IJ. We have an 18 French in the femoral, but that's high pressure. The question we have now is, where are all the flows going? Now we don't know. You can look at the hemodynamics, but how much is going to the lungs? How much is going to the heart? So let's figure that out. There's multiple ways to do that. So go to a full screen. To the overhead, yes, that's perfect. So when we saw the flow, so I'm sorry, go back to the multi. You look here, you can see our flow. Where's my pointer? Yeah, point to it. Yeah, 4.5 liters. And our flow probe is right here. If I take this flow probe and take it off, you see the flow has disappeared momentarily.
Want it closer? Oh,
Yeah, I just need to move this. And if I put it on the leg portion, it reads 4.6. Well, that doesn't make any sense. So unless I've blocked this off. Let's see. Yeah, that's not flowing. That's why.
Is it kinked when you flipped it back over?
Yeah, it's kinked. I'm doing a terrible job of this. I'm sorry. I think I made this
His guts are in
line
the way. You want me to pull it back?
too long. No, I think I just need to put it in the right position. That's, oh, here, I know how to do it. Okay. There. That might be the ticket right there. Now, what do we flow? There you go. Now, if I move this, I'll put that, cover the patient back up. Oh, what happened?
He's
oh,
modest.
I did that. Okay. If we put this on here, now we're splitting the flow. We were flowing 4.2. We're flowing 3.3 there.
Mm-hmm.
In theory, we should be able to hook it up to that and know what that flow is. It should be, you know, well, it was reading, what was it, 4.2? So it seems very odd to me. I think maybe I'm just really messing that thing up. We may have to pull that cannula back some. We do.
Okay.
So we have to just make an adjustment. I'm sorry. I didn't do a good job doing that. So just pull that back some. Keep going. Keep going. Yeah, that's good. That's good. So we'll just, in theory, okay? Theoretically. That's not a very well-positioned cannula, but that's good. It works for the purposes. That's good. We don't need to tape it. I wouldn't even worry about it. Okay, now we're reading 2.36 here. And I'll change this over to here. And that's reading 2.84. So 2.36 and 2.84 equals 5.2.
Mm-hmm.
Let me look at the total flow. 5.2. So you can do it that way, okay? But where are you going to leave it? Where do you want to put it? Because you're not going to do that every 15 minutes. You're not going to do it every minute by minute. So you have to do something. What are you going to do? Well, I got the solution for that. Makes it very easy.
Okay.
Go ahead to full screen on the overhead.
Mm-hmm.
Have you ever seen this before?
Yes. It's on my Christmas list.
Should have been on the Christmas list last year. This is the, let's see. There we go. This is the transonic ELSA-meter. I'm going to go ahead and get it turned on. And can you pull back on that overhead, Eddie?
No, that's as far as that goes.
That's as far as it goes? Okay.
Do we want to put it up here or?
Yeah, that's a good place for it. Well, I wanted to see it, though, so I'm going
Okay.
to set it like, I'm just going to set it on the patient. We would normally not put anything on the top, but I don't know. I do it all the time. I would put stuff on the patient. I do it.
They're
You know.
helping.
But you ask, yeah, can you help me, sir?
Yeah, come on. Do something.
Exactly. You know.
Quit
You have
just
any
laying
idea
around.
what your bill's going to be? We'll give you a discount. Okay. Now, this is the beauty of this. It's so incredibly nice to have this because you have your total flow. Go back to the full screen, but leave that overhead on as the preferred one. Yeah, there you go. You see our flow, 5.1. Again, we can move the thing back and forth, but we don't need to. Uh-oh, we moved our pressures.
Yeah, you move it.
I didn't do it. Don't blame me. I'm not over there.
The card has to be rolled back just a little.
Who moved the cart?
I touched it.
See it on the screen?
Yeah, I could see it. We just got to move this. You can't move anything. Holy sh! Surprised David didn't have a fit.
I did, but I signed it.
There. That's good. That works. It's a little wonky, but it'll work for today. Okay. Now our ELSA meter's up. So go ahead and go to our ELSA meter.
Go full screen.
The screen on the overhead, camera 5. There you go, okay? And I'm going to put these on. I'm going to put this one on, the arm going to the leg, which is arterial. So I'm going to use the red one. That's going to be here. And I'm going to put the other on the one going to the head in the direction of flow. And we'll come over here and we'll hit set flows, display 2 flows. And now you're able to read the flow going everywhere. Well, that's not going to be, can you go, yeah, you can see it right there. There you go, display 2 flows there.
Go closer to that.
Yeah, can you go a little bit closer? Just let people see the flows right here. That's good. That's perfect. I like it. Okay, so what the beauty of this is, and some people use Hoffman clamps. I don't care to use Hoffman clamps. I prefer tubing clamps. It's just how I've been trained. It's what I'm used to. But if all you really need is a leader going here, I can put a clamp on there, and you can see how easily I can modulate that flow and a little bit more. And the reason I use those clamps is because then I can just go to the next level. And usually I'm pretty good about being able to bite these things and get about what I want. So now we're at 940. I could maybe make a little difference. I can try turning the flow up a little bit if I wanted to. I could just move this just ever so slightly and get a better number. Whatever it is that I'm trying to accomplish, I can do that just using tubing clamps. Now you have to remember you're running the risk that the tubing clamp could pop off. And so I don't think that the Hoffman clamps are bad. It's just not what I'm used to. But I will tell you, you take pretty decent bites of this to get the flows exactly where you want it. What happened? Oh, shit. Ah, they couldn't read that. That's okay. They couldn't read it. Okay, good. Okay. I love the way your eyes got big. Okay, so I've read it about where I want to be. 4 liters going to the femoral artery for systemic flow, and you have a leader going to the thing. and our gases should be much improved because now we're providing that supplemental oxygenation. Now, here's where it gets really tricky. How much recirculation do we have? How much do you think we have? We don't know.
No.
But what does this device do?
Checks the research.
It'll measure it, and we can do that, and we're going to do it right now. We're going to
Okay.
actually check the recirculation. So I'm going to grab my 50 cc syringe. Usually you would use a 20 cc syringe, and for this demonstration I use alcohol because it has a different viscosity and therefore, or density, and therefore it will it'll read, the machine will read a little bit easier. And I need 20 cc's. That's pretty doggone close. There. That's good. Thank you. Okay. So now we're going to set the device up the way it should be set up in order to be able to do this. And I want to make sure that I have this set up properly. And I want there to be some recirculation, so I'm going to allow for there to be just a little bit, just for demonstration purposes, because I can make it 0, I can make it whatever I want it to be, but in real life it's going to be what it is. And since we're flowing, you're draining from the femoral vein, which may be in the right atrium, and back into the right IJ, there's a good chance. In fact, can you go to my slides? Yeah. So I wanted to kind of go over a little bit of, what differential hypoxemia looks like. And when you're on ECMO, you really have 2 circulations. And if you look at A, you have the circulation of the ECMO and the circulation, basically no circulation of the heart, because you're flowing enough. But if you are very little recirculation, very little problem, because you see the very small blue line. But if you look at the left, with the heart recovering and the lungs not working, you see the 2 different circulations in B. You have the ECMO going around in a circle, and you have the heart and lungs going around in a circle, and that's sort of and you see the red and the blue coming down, creating the mixing cloud. And then in C, you have those dual circulations, just like we had before, only in this particular case, the lungs are actually working, and I think that's important to see. On the right, you can see how that may affect various organs, with the brain being the most sensitive and the most likely to have a problem. Why you have to put it, why you need to measure blood gases in the right radial, because it is the farthest away from the groin. If you're centrally cannulated, it doesn't matter as much, but if you measure your gases in the contralateral femoral artery, they're going to be fantastic. If you measure it in the left radial, it may be okay, but it has to make it all the way across the arch and over to this side. This is the farthest point away from the femoral artery, although it actually could be the coronary, so you have to take that into consideration too. Your mixing cloud could be anywhere from the top of the aortic valve all the way around the arch down into the descending thoracic aorta, so you have to remember that. And this is such a nice diagram of it's animated, watching the heart pumping out blue blood, the ECMO pumping red blood up that you see there, and the mixing cloud in the purple region is what we will sometimes see with a lower than expected saturation, but at the same time, it's okay. And we think we're okay, but we're not if we're not looking at that in the right side. It's so important. Okay, so we could increase flow. We talked about that. Add the right IJ catheter, which we did. We couldn't increase flow because we were restricted. And this is just showing the Hoffman clamp I talked about. I use a tubing clamp, but Hoffman clamp does make sense. And we've done exactly what you see here. draining from the femoral vein, returning to the femoral artery, wide off. We just created this exact thing that you see here. And then let's do it, which we in fact did. Now we're going to measure recirculation, so I'm going to show you how to do that. So in order to have this be valid in the VAV, I have to stop the arterial portion of it because it's going to confound this test. Normally, recirculation is only for VV ECMO, never for VA ECMO because it wouldn't make sense. So VAV is an exotic cannulation and you can't do it. So to measure this, I'm going to go ahead and clamp this out and just leave this open and let this run to see what that recirculation is. And we're going to put these on the correct direction. So this is my return. This is my access. So I'll be reversing these. So this will go here. And this will go here, this way. Okay. There you go. Oh, here, we can do this. Here, just do like this.
Have him hold it.
There. Thank you, sir. Thank you, sir. He is very helpful.
It's very helpful.
Okay, so now that I have the probes in the correct place and the correct direction, this one flowing this way, this one flowing this way. Now, I have to tell you that, and this one flowing that way, this is very hard to do with a McKay cardio help, not the oxygenator McKay, but the cardio help, because the pump head and this are integrated together and it will not work as well. But any other oxygenator, it does tend to do that. And what you're going to do, and let me get the air out of the system, so I'm going to turn this completely off and de-air it a little bit. There you go. That's good. A little bit of air won't hurt. So I'm going to turn the flow to 3.5. And your point of entry for your, what would be saline in a patient, 20 cc's of normal saline, is between the pump head and the oxygenator. And it will ask you when you set it up how much volume is between here and here. And I calculate this to be about 20 cc's. And it needs to know that because it's going to measure oxygenator blood volume. So first let's add the patient. Accept. Find patient. And this is, I don't remember who this is. Well, I don't remember this patient's name. I think it was,
MC.
do you remember what I called him? Sim?
Sim, yeah.
No, it's not that.
Sim MedWeb,
Where?
right there.
Oh, yeah. Oh, you're so smart. Thank you. There, click that. Measure patient. VV ECMO. I'm going to put it on VV. Recirc and oxygenator blood volume. Hit OK. Now it's going to go through a one, and there's going to be 20 cc's, as I told you. And now it's going to go through a 60-second calibration, which it'll do the countdown there. I don't know if they can see that or not. Right there. It's doing its calibration right there. Good. There you go. 45 seconds. There you go. 40 seconds. And we'll let it go through its process. Very good. And then once we have this, we should have, of course, again, and I want to stress this, can you go back to maybe some camera 2 or something? We can talk, Kimberly and I, and they don't just keep looking at my waist, although it's very elegant looking.
So trim.
So trim, yeah, I know. Yeah, just come on over here.
Okay.
But it's, I think, very important that we make sure that we utilize these tools properly and how we use them and what they're for. So we could have run the oxygenator blood volume with the VA, but in order to run recirculation, I would have had to, if even it was a patient, I would have had to cut the arterial portion out of it in order to run a recirculation test, and that's important to understand. There are other ways we can do it, which is to look at the venous oxygen saturation and the difference. So it would have been important for me to have known what that was back here, or here, prior to initiating this, and then looking at that change to know how much recirculation we probably had, because that would have been a different way we could have done it, because we wouldn't be able to measure this test. Okay, let's go to the overhead, and this is ready. You want to do the squirting? So remember how to do it? It goes here. Apply pressure, when I tell you, before you turn the stopcock, so that it has to go in like this. It has to go right in, okay? So I usually apply pressure and then don't do it yet because I haven't hit the button. Slowly turn and inject it. So you'll watch her do that and we'll know if it's a good injection. Ready to measure, and you can go anytime. That was pretty good. Close the stopcock, and this should pick it up. You see it's analyzing. Can you zoom in on this a little more?
Yeah,
There you go. And it takes about a minute from the time you do the injection. And so we normally use 20 cc's of normal saline in adults. I don't do kids either, so I can't really tell you. I know that it's like a 0.5 cc's per kilo or something like that. But it says it on here. I just don't ever do it. That was a good waveform. Actually, there's zero recirculation, was zero. So I'm going to make it worse than that. That's not enough for me. I wanted it to be much worse. So, and I'm going to draw you up more saline or some more alcohol, and we're going to do it again. Yeah, it's good. About 20 cc's. Pretty close.
A little bit more. Oop.
That's all right. It's just alcohol. You can use tequila, but it's wasteful.
It's very wasteful.
Okay, because you can't drink that isopropyl. Okay, now this time a little faster of an injection.
Okay.
Okay, so we're going to run it again. So let's look at this again closely. Tight shot. I'm going to go to measure patient. I'm going to click ready to measure. This time a little faster.
Okay, you ready?
Ready. That was good.
Hands are all slippery.
Mm-hmm. It's analyzing. I'm hoping you have significant recirculation. It is what I'm hoping. But it's always, we're always like we're watching. I sit there and watch. 35 seconds to go. It's like I want the results so fast. I get very excited. I get very excited about this.
Remarkably calm Joe. I don't know what you're talking about.
Well, I get excited. I'm still calm. That is my nickname. You want to tell them a story about? You got 15 seconds to tell them about Remarkably Calm Joe.
Oh, what were we switching? I don't even remember. Oh, oxygenator.
Yeah, we're changing oxygen.
Yeah.
I had Rodell helping me, and God knows.
It was only momentary
you know
dead
what?
for the patient. It's only momentary.
You know
it's just
what?
a second.
I do it a lot better.
It's a little peek at the bright
Yeah, there you
light.
go. Look, recirculation was 20%. Very good. So I'm excited about that. So it can give you some valuable information. And of course, look, compared to the previous, your oxygenator blood volume is 101%. If somehow it gained volume, but it's within margin of error. And there's no reason. So if your oxygenator blood volume, once you have a baseline, had shown, let's say, 70%, the only thing that could be occupying space in that, it's not going to be styrofoam, it's going to be clot. And it's a really good way of knowing whether or not your anticoagulation strategy is or is not working. And that's really helpful to know, especially when you're doing low to no anticoagulation. I think it's very important to do this.
Yes.
Okay, well, I think we can go to back to the regular screen, and we're gonna close. Do you have any, you wanna play? Do you wanna do anything? Is there anything you'd like to do? No? You sure? Do you wanna take a scissors and cut the tubing?
No.
of Joe's crazy simulation. What do you think?
I
mean,
like
it's
it.
not perfect,
Yeah.
and I think we could make it better. It's hard to do it online.
Yeah.
I think in person, I'm gonna cut this off. In person, it would be much easier.
Yeah.
But to do this, we're on that camera. To do this online is challenging, and I keep learning. I keep trying to figure it out. I think there are some things that we can refine. It's going to take time, but eventually it's going to be really great. But this is why online education is great. Doing things remotely, webinars, it's great. But when you're doing hands-on stuff, it's really challenging. And David, you've done an excellent job. Darcy, you did an excellent job. Thank you both very much for your help with all of that. It's challenging. It's hard. Nobody knows what I want to show. Hey, and of course, I don't expect David to know what I mean. Can you show the vent? Can you show the patient monitor? Can you show the and you know, he's not a medical person. He's a production engineer.
Yeah.
He doesn't know. So you have to top left corner, do this or do that. So yeah, it's a challenge, but it's fun. So
Yeah.
tell me, you wrap it up. Let's just tell our audience something positive, and let's get the hell out of here today.
Our patient lived.
Our patient lived. Dang. I appreciate it. Did we name this guy yet? She thinks I should name him Phineas.
Phineas, yeah.
I'm not in love with Phineas. Phineas Gage, that was it.
Phineas Gage. What's wrong with Phineas Gage? Joe Jr.?
I didn't even know who Phineas Gage was because she had to tell me. No. So she told me, okay, you know what? Send me an email. Give me some suggestions. If you...
Simman. Name
If
Simman.
yes, right. If we use the name you submitted, Simman, the name you submitted, I'll give you a, how about $100 Amazon gift card.
There you go.
That's good. $100 Amazon gift card. If you submit a name and we use it. Okay? Sounds good?
Absolutely.
So do it. So
Yep.
y'all help me think of something. All right. We'll see you all in
time.
July 26th. And we're going to work on this, David, a little bit more between now and then so that next time we do it, because that's a whole 6 hours of simulation. So we're going to
Yeah.
have to really work on things, which we will do. And we'll see you then. Bye.
Bye.